yet. Maybe one more year. Okay, thank you once again. A former faculty chair, Dr. Diaba is also here, and Dr. Aye, the founding president of SEPOC. In these sessions, we have a very packed menu, according to our lifestyle menu. So we have some oral presentations, a workshop and oral presentations and scientific sessions, and then also we have presentations from our sponsors. I'm going to probably need someone to help me to keep the time so that would really go through it quickly. I will entreat all presenters to kindly stick to their time. No elaborations, just go straight to the point so that we can go through it. Everybody would have an adequate time to make his presentation. I think the first presenter will be from Boehringer Ingelheim. Okay. So it's the firm is being represented by Dr. Farm Prince Alex Apj Osei. Please let's welcome to make that presentation. Thank you.
Thank you very much, Chair. I'm really grateful. Yeah. Thank you very much, Chair, and thank you all for having us. Yesterday, there was a presentation on empagliflozin, and so as much as possible, I won't be talking about data because I believe that all of us here know so much more about Jardiance. But it doesn't end with just the knowledge. I believe that when you are meeting the patients in your clinics, the diagnosis is not a problem because that's your expertise. But when the patients go home and they are not getting better, most times they won't even come back to you. You'll go to another prescriber. And sometimes the only thing that changes is the drug. They get better with that prescriber and then it makes them think, oh, this doctor is not good. I'm not going there anymore. But you did your best. The problem is us. Maybe the drug that you wrote, which was supposed to come from us, didn't help your patient. And so as much as possible, when we are prescribing for our patients, the selection is very important. When it comes to our patients with heart failure, chronic kidney disease, and diabetes, we know that now it's becoming very interesting. The numbers are becoming very interesting. But when it starts with just diabetes, we could have prevented the heart failure and the CKD by giving them some drugs that offer protection, like Jardiance. Please, next slide. We know this already, that 2 out of 3 patients with type 2 diabetes will die from cardiovascular disease. And then patients with CKD are 3 times more likely to have a cardiovascular event. So it behoves on us to give them the drugs that would prevent the kidney disease, prevent the heart failure, as well as give them more glycemic control. Next slide. If you're meeting a patient who is 60 years today with a family history of diabetes, with dyslipidemia, hyperglycemia, yes, you may be giving them anti-glycemic agents that makes their blood glucose control very good. But we are not protecting the kidneys. And so we are also helping with the numbers that will end up with dialysis. Next slide, please. Next slide. Next slide. Next slide. Next slide. Okay. Jardiance is able to reduce progression to nephropathy by about 39%. But what does that number mean to us? In fact, from the EMPA kidney outcome trials and the EMPA reg outcome trials, there's been some hypothetical calculations to show us that if you are meeting a patient today whose EGFR is 85, then in the next 17 years, without putting them on Jardiance, they are going to end up with end-stage kidney disease, and so they are going to need dialysis. But if you are giving them today Jardiance, you are giving them 44 more years before dialysis. So it means the patient is 40 years today. You are giving them up till 84. I believe that as much as possible, patients at 84 needing dialysis, that's not so strange. But if 40 today, in 17 years, that's 57, 3 years before they even get to retirement, they need dialysis, then that's something we should look at. And so not just the glycemic control. In fact, I have seen patients with HbA1c of 14.7, and in just 1 month on Jardiance 25, they are recording 8.2. That's something that happened last week. I think when we had a presentation, I mentioned that. Next slide. And so we are more interested in medicine that would protect our patients, reduce the progression to kidney disease and heart failure, as well as control the blood glucose. And for a drug that can even be used up till EGFR of 20 ml per minute per 1.73 square meters, it is taken once daily. You don't have to worry about it at all. And it is very safe and tolerable. Next slide. According to the ADA and EASD, if you have a patient whose glycemic, HbA1c targets is more than 1.5% from the goal, then you need to give them a drug like Jardiance with metformin, the combination. And so we present to you Synjardy, next slide, which gives you, next slide, which gives you all the benefits of Jardiance together with metformin in one drug at the same price. Synjardy comes as either 5/1000 milligram or 12.5/1000 milligram, and it's given as BD. So that at the end of the day, you have either 10 milligram of Jardiance daily with 2 grams of metformin, or 25 milligram of Jardiance with 2 grams metformin. And you get all the benefits of Jardiance as well as all the benefits of metformin. Next slide. And so in summary, I'm telling you that Jardiance is doing all the magic we need for our patients with diabetes, whether it is with protection or curing them. I'm not saying that they would be cured from diabetes, but then they get the glycemic target that we want them to have. And they are happy. We are also happy. We can all sleep in peace. Next slide. And if you ever want to do Synjardy because the patient's HbA1c is more than 1.5% the target, know that you are getting all the benefits from Jardiance at the same price, and we are dashing you metformin. Thank you very much for indulging me.
Dr. Pharmacist, you are wonderful. I mean, if all should go through the presentation briefly, a round of applause to you, please. Thank you. Maybe I'll allow for a question, if you have a question or two, because he went through his presentation quite rapidly. So if you have a question or two, I would allow him to answer. Yes, please. Is someone going around with a microphone? Yes.
Hello? Hello? Okay, I think my question is about the cost. That's all.
Okay.
Thank you.
Thank you. So both Jardiance 10 milligram and 25, as well as Synjardy 5,000, 12,500 is selling at 714 cedis. Yes, please. That's the wholesale. I cannot tell the retail price because different pharmacies will have different prices. But as much as possible, I know the wholesale. That's why I'm giving the wholesale. Yes. Okay. Okay. Thank you very much.
Thank you very much. So for the next 1 hour, we are going to have a workshop. And this workshop is about the reason why we have this AG SM, and the World Family Doctor Day, in essence, it has to do with digital health. So we want to, Jojo, have some discussions on digital innovations in primary care. And to lead this session, we have none than one of our hardworking family physicians. Is the director of medical services, KNUST Hospital, and a senior family consultant family physician. I think currently the secretary, president-elect of Wonka Africa, right? All right, that's a great one. So I'll make a few comments on that later. Right. So I'm talking about Dr. Med Nana Kwame Eyisi-Boateng. Let's welcome him.
Thank you so much. Good morning, everyone. And if Professor Suman is refusing to be referred to as an ancestor, then obviously I'm a small boy, just beginning. I want to stand on the existing protocol so beautifully established, with your permission, Prof. Chair. And we'll quickly go through the slides that will introduce us into the scientific workshop. And I've been given a task for us to look at digital tools in primary healthcare and how we can improve primary care through digitalization, through compassion. And as we know, the theme for this year's World Family Doctor Day is in line with compassionate care in digital health. Okay, please be moving my slides for me. Right, so the objectives here will be to identify key digital health tools. We are going to explore the benefits and challenges, reflect on compassionate care, and apply our learning in practice. Next slide. And why is this so important? There's a rapid expansion of digital health currently. We're looking at the introduction of digital health more to bring about efficiency. But we know that in trying to achieve efficiency, there's also the workload part of it. And we are trying to balance that efficiency with work and the challenges associated with introducing digital health in our practice. And then we'll explore the impact of this digital health or the tools that have been introduced on doctor-patient relationships. Next slide. It's working now. Okay. Please go back. So there are a few digital health tools that we'll be looking at. The commonest one that most of us are familiar with is the electronic medical records or the electronic health record system. We also have telemedicine and virtual care, which is catching on, a video teleconferencing. And then we also have the clinical decision support tools. Medscape has been around for some time. We also have diagnostic alerts. Sometimes we need to input a few indices into AI and then get results in guiding us in terms of diagnosis. And then data and population health management. Remember during COVID, there were dashboards. And even when you go on the WHO website, there are dashboards that give updates on some disease conditions globally. Then remote monitoring and wearables. Some patients have their own BP monitors, glucometers. They monitor, as well as these wearables that can give alerts in terms of how many steps you have made or how your cardiac activity is going on. There was a patient of mine who was alerted about her heartbeat moving fast. And indeed, when she reported to the hospital and did an ECG, she had an atrial fibrillation. So these wearables are also available. And then patient engagement and self-management tools, medication adherence, getting alerts on when to take your medication, drug-drug interactions. Then we have the digital medical education and health training platforms. Like the Ghana College of Physicians and Surgeons has the ePort training platform. West Africa has its own. And some medical schools have also introduced this. So this is one area that we would be discussing. And of course, we know about AI and other emerging technologies. And then POCUS, I know SoftPOC has been leading in efforts in training people in makers' attention to these digital tools. So we'll get the data from this, get your perception on digital health in 6 main domains. So we'll discuss the benefits, barriers to adoption. We'll look at ethical and safety implications, and then how relevant Group, please, you have 1 minute. Time is up. Group, please get ready to do your submissions. Time is up. Please let's get back to our seats. Group 1, Dr. T. Dr. T, let's hear you. So we'll go through each of the questions. They will just share the highlights of the submissions that were received from participants. So we'll take them. It can be with you. I mean, but when I present, I think just crystallize it. Over for question 1, and maybe 1 or 2 things that came out. All right. Yes, Group A. Either the group lead or the scribe can present, depending on who you elected. But just the highlights. We have 3 minutes for each group, 6 groups, so it means we have 18 minutes to finish this exercise. Group A. Group B, please get close. Oh, let's put our hands together for them. Yeah.
So good morning. So we are presenting on electronic medical records. So the first question is, in your practice, have you or your colleagues used any tool in this category? And the consensus was that yes, almost all the participants have used electronic medical records. Yeah, and then some of them are in private, and then some of them are in public way. So if yes, which one? Okay, so most of the public institutions are using the GIMS, and then previously most of them were using the LIMS, and then private institutions, some of them are using PAL, and then Serenity, and other private electronic medical records developed specifically for their facilities. And then the next question, benefits or burden. So does this category of to improve comprehensive collaboration, quality, patient-centered continuity, efficiency, safety, and compassionate care? And most of the time is yes. But the burdens, he wrote it, I have to try to read it. Some of the burdens include delay, and then what are they? They improve patient care. But when the network goes off. So one of the main burden is network. When the network goes off, there's chaos. And then some of them, they have to resort back to paper records. And when they're not, they move it to the system. And then another main challenge is data loss. So the data loss can be due to within, like, when attending to the patient moved from consulting room to pharmacy, and by the time they get to the pharmacy, there's no data there. So they have to send the patient back to the doctor. And then the second one is when the patient comes for review and they go into the record, you realize that the data is not there. So they have to retake the history again. Other challenges include user-friendly. Some of the users are not familiar with the electronic medical records. And then there is this political interference. So maybe when there is a change, then you have to reintroduce a new electronic records. And then you have to train the doctors, train the user familiar with it, change again. So it's everything more difficult. So recommendation. The main recommendation or our main challenge is connectivity. It's like connectivity. So internet and then electricity. When the electricity goes off, you lose data. When the internet goes off, then you can't work. So our recommendation to SOFPOC is that family physicians should be parts in advising and in design of electronic medical records for users. Thank you.
All right, let's put our hands. Well done. We'll take questions after all the groups present. Yes, so Group B, Joyce Inoni.
So good morning. We are Group B, and I think our topic was telemedicine and virtual care. So yeah.
Thank you very much.
I would advise that the scribes should present what they write.
Thank you very much, Dr. Noni. So for us, the current reality, we asked participants whether they've used telemedicine before. And then for the yes answers, the reasons were for teleconsultation, laboratory review, prescription refills, mental health monitoring of soldiers, and then phone or audio. Some did only audio consultation, and then for remote monitoring of blood glucose and blood pressures. And then for those who answered no, the reason, and it was a unanimous decision, reason was for lack of opportunities to use telemedicine. And then our question 2 was on benefits or burden. For the benefits, it reduces patient waiting time, it improved continuity of care, and then reduce the costs to patients, particularly for transportation costs. And then it's also convenient and efficient for patients. Under the burden, one of the main burdens with what participants brought out was combining the use of telemedicine with inpatient care. That was quite a big challenge. And then it offers no opportunity to see your patients. And then one of our participants mentioned that even for certain patients where you know that telemedicine will benefit them, for example, for prescription refill, some of the patients still wants to see your face. And that is, one of the burden, because the patient will still want to see you when you have other patients that, require more time. And then under Ghana, under burden, we also had network challenges was one of the main burdens. Network challenges where you are seeing a patient and then in the middle of the consultation, especially when the patient wants to give you a very important information to help with your diagnosis, then the network goes off. Yeah, I don't want to mention any companies, but you all know. Yes. So barriers, for Ghana specific barriers, access to use of mobile devices, privacy and data security. And under that, we also included, the data storage problems, challenges. And then the group A had already mentioned the games, the LAMS issue, where we don't have data. We've lost data for a lot of our patients, a main challenge. And then for recommendations to SOFPOC, one of the participants contributed that SOFPOC needs to look at developing our own app where it can improve the network of practice in that patients who can actually choose which particular family physician is available in a particular location and then have access to care. It will also help the other recommendations, collaboration with pharmaceutical and laboratory companies, because after you've seen the patient, you need to prescribe medications and then also run certain laboratory. So if you have that collaboration imputed in the app, that can give a comprehensive care. Thank you.
What would be the name of the SOFPOC app? Group B, what would be the name? SOFPOC Med app or something. All right, well, that's a good one. Let's put our hands together for Group C.
Thank you very much. So this is Group 3, and we were supposed to look at a topic. No, it's not here. Clinical decision support system in AI. Yeah, so Bismarck will take over.
Thank you, boss. So for Group C or Group 3, so this is what we found during our deliberation. So for the current reality, most participants in the group have used one AI tool or the other. And examples indicated included ChatGPT, Medscape, ASCVD calculator, CKD calculator, up-to-date digital colposcopes, AI-assisted radiology tools. I mean, for either information or helping with diagnosis, and just to improve care. Yeah. So these were the things that came up. A specific example, let's say the AI-assisted radiology tool. I'll let my boss elaborate on that because she has used that.
So in TB screening, they have this chest X-ray machine that is able to take the X-rays, and AI automatically would highlight all the areas that suggest that this could be suspicious of TB, and so you have to look at it. So most of the time they use it in doing TB screening when they go into the communities, and it's an easier way of, it helps them in making the decision, especially if you don't have a radiologist available immediately. So that's one of the tools that we discussed in our group. And we also had the colposcopy. So the AI-assisted colposcopy, where the patient comes in, you do the colposcopy, you see the image. When you see the image and you're too clear, you have the opportunity of taking a picture of whatever image you see and sending it to your boss or a specialist to be able to interpret these tools for you.
All right. Thank you. So the benefits or burden. So in all, what we agreed on was that these tools actually it helps improve care. It provides us with evidence-based information. For example, use of up-to-date. So you know that the information you're actually getting is evidence-based. It also helps brings about efficiency and compassion of care. It doesn't really add up to workload. I mean, we didn't find that, but with the burden, the only things we found or that were highlighted were the fact that it's internet dependent, and so mostly when you don't have internet where you are or with the device that you are using, then you are sure that you wouldn't be able to use these tools. And also highlighted was the fact that these tools were designed elsewhere, not in our population. They were designed and tested in populations that have certain dynamics that are different from our own. So sometimes it may create a bit of a problem, even though it's somehow reliable, or should I say reliable in most of the time. And then also over-reliance of these tools may also lead to clinical judgment. That was another thing. I mean, would lead to the loss of clinical judgment. So sometimes you tend to forget your clinical skills or your clinical thinking and to want to rely solely on these tools. And by and by, you tend to lose the clinical judgment. That's yes. So one big recommendation that came up was that these tools are good. They help us in our practice. So SOFPOC should identify AI tools relevant to family practice and provide training on the use. Because one specific barrier that we highlighted was the fact that some of these tools actually require training. I mean, they are such that if you don't know how to use them and you misapply them, the results that you get will be something else, garbage in, garbage out. And the other recommendation was that there should be advocacy on the integration of these AI tools to the EMRs that are available in our practice, so that it will be easy to apply or to use. Yeah.
Thank you so much. Right, next group, group 4, led by Dr. Dora Egble, scribe was patience. Amanopo. Right.
Good morning. My scribe will speak.
Good morning. Group 4, we looked at self-management tools or remote monitoring and wearables. So our current reality is that we are using some of these tools. Patients use glucometers. They have BP measuring machines in the house. We have peak flow meters that we use. We also have the continuous blood glucose monitoring devices. And then some of us are using apps. Our senior colleague is using the Lucy app in his facility, where they used to monitor patients with hypertension and diabetes. We said that they are helpful because they help patients appreciate the numbers, and that it makes them come in earlier when they realize that their values are high. And the telemedicine will help the patient, the apps help the patients get their vital signs without having to travel. And so it improves compliance and adherence of all the patients. We also said that the NCD app, which is the Lucy app, helps them with self-awareness and self-management, and therefore it saves cost. We said that the tools, these machines that they use, are beneficial, and it doesn't necessarily add to our workload. We just need some time to train them on it. We said that patients, the risk is that sometimes patients get comfortable when they are monitoring themselves at home, and so they think that they do not need to get to a doctor to help them out. And we said that for the barriers, there's a problem with connectivity for those who use the app and they need a smartphone. But then for the common machines that we use, like the glucometer, the cost of the strips is sometimes a problem. And sometimes even when their strips get finished and they are not able to get strips for that particular machine, they need to buy a new machine. And the cost of the machine itself is the BP monitoring machine. For some patients, it's high for them. We said that for the Ghana-specific barriers, cost is one, temperature is another one. For instance, the continuous blood glucose monitoring machine like this, you need the temperature can affect it. We said that our literacy rate is low, and so we need to train the patients more on how to use the devices and how to interpret the values. Internet connectivity is a problem. We also said that the policy in the country is a challenge, because sometimes there's policy. For instance, there are a lot of machines in the system that are not FDA approved. So even though there's policy, it's not being adhered to. And then health financing is a challenge for most of our patients. What should SOFPOC do? We advocate for, we say that they should advocate for awareness for both the providers and then the patients on the availability of these devices, and then train us on how to use it. And then if they could get NHIA to pay for glucometers for the patients with diabetes who are especially on insulin. And then if they can get companies or the pharmaceutical companies to discount some of these devices so that the patients can get them at a lower cost. Thank you very much.
And SOFPOG after AGSMs can distribute wearables to everybody, every participant. All right, next group, Dr. Steven Engman, medical education. Let's put our hands together for them.
Good morning. So Nanekia.
Good morning, everyone. So ours was on digital medical education and training. Our first question was on whether we had used any learning management systems or any tools worth of digital importance. And for our group, it was an overwhelming yes. From the Ghana College Library to Zoom platforms to people who work at CATH, there were platforms where the family medicine department actually has a portal where you can access all the information that is given. In the UK, they have lectures on a platform called Moodle, so you could also get all that information. The Wonka website, and then Lecturio as well. YouTube, I'm sure Geeky Medics, all of us who have done residency made sure that we were on Geeky Medics 24/7. And there was one new one that we learned about, Anatomage. So it's actually a virtual dissection platform where you can do virtual dissection instead of using cadavers. And I'm sure a lot of us would have had less stress as a result. Now, is there a benefit or a burden? So we did say that there were some benefits to it. We would be able to connect to a wider range of people in a shorter space of time. It was quite convenient. It was faster to be able to use. And we would also target people who are in remote areas who cannot connect in person. But then we would, looking at the burdens, we would say that there's an over-reliance on digital tools. Sometimes people who are not able to join in end up leaving. Then also lack of resources. Data is a problem. Connectivity is a problem. And then we can also have a short attention span. Someone says their learning environment may not be conducive at the time. So I may be connected, but not fully participating because of other competing interests. Now, for Ghana-specific barriers, we had stable internet was a major challenge for us. Electricity challenges, poor IT knowledge and skills, financial barriers. Paid subscriptions are quite expensive, so people don't want to use that. And then culture of acceptability. Sometimes we just don't want to use these platforms. We are used to what we are used to. And then also access to the devices for use in particular can be a challenge. Then recommendations for SOFPOG, we talked about awareness creation on existing digital platforms, subscription bundles for specific platforms so members can utilize them. Then digital education incorporated into the undergraduate curriculum. Then practical sessions on how to effectively engage these digital tools, because sometimes we watch it, but using it in practice becomes a very big challenge for us. Then also clinical learning on our SOFPOG websites will be imperative. The last one was also particularly important, linking mentorship with persons that were well vested in digital tools so we can learn from them. Thank you.
They had 5 seconds remaining. So now let's see how the last group will do it. Dr. George Nketia, his group. Anita, you are presenting for them. Please let's put our hands together for her.
Thank you. So for our group, we're looking at POCUS and then other low resource context-specific tools. The tools we spoke about were point of care ultrasound, digital spirometry, digital x-rays, and then point of care lab analyzers. So when it came to the current reality, those 4 were what people had used. They mentioned that it was low cost for patients, and it was used for both inpatient care, outreaches where they had to go to hard-to-reach areas, and also for occupational and industrial health use, and then trauma assessment. So those in the hinterland, when they get trauma cases, they're able to use POCUS to quickly assess and intervene. So when it came to the benefits or burden, largely was a benefit. There was improved efficiency. So you see the patient, you do your POCUS and other points of care test, you make a quick diagnosis. For some, you can quickly intervene. So you actually have the family physician doing everything. But the burden to that was it increased the workload for the family physician because you don't involve others. But the other side was also that for some of the tools, you can easily send pictures and videos to other specialists. So in that instance, it actually increases collaboration with other specialists. Then there was improved quality of care. When your patient comes and you are able to do everything for the patient and you don't have to necessarily refer outside, the patient actually gets the best care at that particular time. Then also in terms of safety, POCUS, for example, enabled much safer procedures for some patients. The burden was also in moving some of the tools outside. So for some of them, you really have to get extra transportation requirements to move the tools outside. You have to be extra careful because they are expensive and they are fragile. And then also for some, the consumables are expensive. So when you get the initial cost is high, even though it is low to the patients, for you acquiring the equipment, the initial cost is high. Then calibration of some of the tools is also an issue. Some of them are very sensitive to changes in temperature, humidity. And so calibrating it can be a burden to the user. Ghana-specific barriers, we've spoken about the electricity challenges, data challenges. Then someone also talked about staff attrition. Because we have such a high level of staff attrition, retraining becomes an issue because you can train people now, they move out, then you don't have anybody available to use the tool, and you have to retrain again. Then also the issue about policy came up, that the policy is there, but you have a lot of machines in the system that are not FDA approved. Who procures? We don't have policy on procurement, on how standards are kept, and the machines are just there and everybody is using them. So the recommendations. Then one of the other barriers was also about trusting the results, because a lot of times you trust the person doing the procedure. So when you don't know who is doing the procedure, then you start raising questions that can I trust the person? Can I trust the results I'm getting? Recommendation training. So SOFPOC should champion training of the use of these tools across board. Probably maybe pick one like we are doing with the POCUS and then just do training every year so we get a lot more people involved. Then policy change. So SOFPOC, like what we are doing now, research, do a proposal, do proper research, write a paper and then present it to our policy makers. Then the last thing was to insist on inclusion of tools at every primary care center so that we influence policy such that when they are procuring tools for maybe every polyclinic, every health center, they make sure that there's a POCUS machine included in the things that are needed for that center. Thank you.
As I listened to each of the groups, I was like, wow, family physicians know. Please let's put our hands together for everyone who have participated in this. There are a lot of things that I've learned that I didn't even know existed, and it's been quite enlightening. So let's all embrace digital health. It's here with us. It's about us preparing ourselves to be well trained to be able to use it effectively. But let's remember that there's a human part of it where we cannot replace our human touch with digitalization. Prof. Chair, my work is done. Thank you very much.
Thank you very much, Dr. Isibwati, for this exciting and insightful workshop. We're still racing against time. We want to move on to the next item. That's a presentation by AstraZeneca. If the rep is here, please step forward. Let's welcome him.
Morning, everyone. My name is Desire Puku Asante, a pharmacist and a rep from AstraZeneca. This morning, we'll be looking at highlighting the benefits of Forxiga 10 milligrams, the management of type 2 diabetes beyond glucose. I know that as family physicians, we must have had some fair experience with patients with type 2 diabetes who end up getting cardiovascular complications like CKD and heart failure. And so this morning we are going to look at how Forxiga has evolved as a foundational therapy in the management of type 2 diabetes, CKD, and heart failure. Our research has shown that for patients who are diagnosed with 2 diabetes, about 60% of them will end up getting cardiovascular complications. And as we all know, the heart and kidneys are closely interconnected, essentially meaning that a dysfunction in one causes a remarkable decline in the other, and vice versa. And so I know that in the world of clinical practice, time is of essence, and early intervention goes a long way to help our patients save a lot of lives. And so we are saying that looking at this diagram, yes, it looks like a Venn diagram without a universal set. What clearly it simply implies is that type 2 diabetes initiates a slow cascade in causing cardiovascular complications like heart failure and CKD. Now the big question is, how do we break this cycle? This is where Forxiga comes in. Okay, sorry, I'm struggling with the pointer. So here, in the management of heart failure, in reducing cardiovascular death and hospitalization in heart failure, or reducing worsening in heart failure. Then again, patients living with type 2 diabetes, adults living with type 2 diabetes experience some form of benefits, a remarkable benefits from the Forxiga, the use of Forxiga in the management of type 2 diabetes. Now, the key message here is that beyond glucose control, Forxiga offers a remarkable benefit in management of CKD. So here in the declared TIMI trial, we saw about 17,000 sample size patients, some of which were randomized to take placebo, Forxiga 10 milligrams. Forxiga 10 milligrams was associated with 47% reduction, relative risk reduction in major cardiovascular events like myocardial infarction, cardiovascular death, and ischemic stroke. Next slide, please. Here, we are looking at comparing the benefits of Forxiga 10 milligrams over DPPA inhibitors in type 2 diabetes. So aside from the HbA1c reduction, Forxiga also offers mild weight loss, reduction in hospitalization, and is associated also with renal benefits. Now, I know that in the management of CKD, our patients usually are on RAS inhibitors. Now, it is not enough to put patients on RAS inhibitors. And this slide clearly indicates that patients who are on RAS alone are at a risk of greater than 40% remaining, at risk of 40% remaining for risk of remaining for events. Now, this is how Forxiga, this slide is mechanism of action, Forxiga and inhibitors. Now, we know that ACE inhibitors renal support, renal protection by decreasing or by causing efferent vasodilatation. As I said in the previous slide, it's not enough alone to put patients on RAS inhibitors. And so adding on Forxiga 10 milligrams comes with the benefits. And how does the benefits occur? This is where it comes in. This is how it occurs. So Forxiga 10 milligrams, as you all know, is an SGLT2 inhibitor, which means that it causes inhibition of the SGLT2 in the proximal convoluted tubule. This causes a further reduction in sodium and glucose reabsorption. Now, because there is more, because sodium glucose reaches the mucosa densa, it initiates tubuloglomerular, it activates tubuloglomerular cascade, which consequently will reduce efferents, consequently will reduce glomerular pressure and also cause afferent vasodilation. And that is how Forxiga offers its protection in renal, in CKD. Next slide. So according to current guidelines, for instance, the KDIGO guideline 2024, it is rated as a class 1A recommendation, strongly instilling confidence in the use of Forxiga in the management of CKD. In fact, it is rated as a first line. It is recommended as to be used as first line medication in the management of CKD. So this is the DAPA CKD trial, and it saw 39% comparing comparing Forxiga 10 milligrams to placebo. It saw Forxiga 10 milligrams indicating a 39% relative risk reduction in declining of kidney function or patient progressing to end-stage kidney disease, and also 39% reduction in CV death. This is this graph is depicting that it is not skewed. The benefit of Forxiga in the management of CKD is not skewed to only patients with type 2 diabetes. Even in patients without type 2 diabetes, you see about 50% relative risk reduction. Here, I call it the good news to the patients and to the clinical team at large. This indicates that there is a 15 years estimated delay to dialysis when patients are being identified early and diagnosed of CKD at an eGFR of 75 mils. This tells us the essence of identifying and putting patients on Forxiga early, because at an eGFR of 75 mils, you have a delay in estimated time to dialysis by 15 years. Now, the management of heart failure with Forxiga is a cross-functional benefits, such that you have benefits. Forxiga shows benefits across the range of ejection fraction. Heart failure, whether heart failure with reduced ejection fraction or heart failure with mid-range ejection fraction or heart failure with preserved ejection fraction. Here, Forxiga 10 milligrams heart failure with reduced ejection fraction is associated with 18% relative risk reduction in CV death and 30% relative risk reduction in worsening of heart failure. And also in patients with preserved ejection fraction, we have 18% relative risk reduction as opposed to 26% relative risk reduction in in patients with reduced ejection fraction. So here, very important. We know that patients might have been on several other medications in the management of heart failure. Now, Forxiga is the only drug that has proven to show no change, no attenuation across the eGFR, the ejection fraction range. So be it mild, mid-range ejection fraction, preserved ejection fraction, or reduced ejection fraction, you don't have to worry about the efficacy of Forxiga 10 milligrams. It has shown a consistent benefit across the ejection fraction range. And so at this point, I would like to reiterate that Forxiga is the only affordable SGLT2 inhibitor innovator brand, and it's taking 10 milligrams. It comes in 10 milligrams and it's taking once daily, any time of the day. Thank you.
Thank you very much, AstraZeneca. I think the message is clear. Thank you. Another round of applause for AstraZeneca. So we want to move on to our next presentation. This is going to be our first oral presentation on the point of care ultrasounds in emergency obstetrics, an implementation study in Western and Savannah regions, Ghana. The presenter, know him very well, is a family physician specialist, a medical superintendent, the Kwesi Mintim Government Hospital here in Takoradi. And I know that he's also a senior resident in geriatric medicine, so I'm wondering what he's doing in emergency obstetrics. So let's welcome Dr. Osei-Frimpong. Simon.
So, good morning. Let me say that I, being a family physician primarily, my role transcends all the other sections in the hospital. So, I'm into obstetrics, emergency, and everything. Thanks so much. So, I'll present on this project work done by SOFPOG in Western region and Savannah that we pick some midwives to work on. Focus. Okay. Move it. Or I should move it here. Okay. Okay. So the project review, we all know that maternal mortality is taking up a lot. Looking at the figures, if you are not careful, 2030, we might not achieve the figures. I think we are expected to get somewhere below 70 per 100,000 live births. But now Ghana is hovering around 234, 270. So it's something that we are all worried about. So this initiative came that if we should be able to do something different, then maybe we can bring it down. So our thinking was that when we improve access to ultrasound services, and these midwives who are always in contact with the patients, if they're able to pick swiftly problems, then we think we can bring them down. So what is the innovation? So SOFPOG, in collaboration with Global Ultrasound Institute, Ghana Health Service, provided POCUS equipment to 32 midwives, 16 from Western region, 16 from Savannah. So they all went through this training. Then somewhere along the line, we picked additional midwives to join because the project was going well. So the diagnostic machines and its accessories were given to the midwives. Then we picked the cohort 1, which started somewhere in, I think, October or something like that. So Western region submitted 16 midwives. Savannah also brought 16 midwives. We met them and in-person training started in Buzwa. They all had in-person training and we had a top-up online training, which was in May for the cohort 1. For cohort 2, we couldn't have that luxury of time. So theirs was just a training online. So online training, we first gave it to the TOTs. So those who did the cohort 1 people, we selected a number of them. I think 8 of them, 2 from each facility, to try and help us train the other 50 midwives we picked for the cohort 2. So we provided support systems through the project period. So after the training, they have to always submit scans that we reviewed online. So these mentors were reviewing scans online and doing everything online. I think also we gave continuation of education support to them so that they could master the act. So what value does it cause? It improved immediate obstetric decision making to improve maternal health in Ghana. So these are the teams. I think the national team, Western Region and Savannah team, GASI and instructors were all in. These were the key objectives with the training. So I'll go through the key objectives again. So let me jump over this. And these are the processes we went through. We picked 32 in-person training, monitored. All of them were doing some modules on NTN. Okay. So now I picked the objectives one after the other. So the first objective that we were thinking of was to at least 75% of the 32 trainees would attain proficiency in knowledge and skill in utilizing the POCUS by the program conclusion. We were able to do about 95. This is the results we had. Sorry, we published their names, but out of the 32, it's only 3 of the midwives who couldn't get the 80% mark we were looking for. And even their marks were around 79, 77, and so on. So the second objective was at least 80 of trainers, the ones we picked later, demonstrate proficiency in supervising the hands-on skills training of the POCUS training program and provide adequate mentorship and support to the trainees. We were thinking of 80, but we could achieve 87.5. And this is the results. So the GASI fellowship or fellow assessment, we gave it 60 marks. District coordinators assessment, we gave it 40 marks. It's only one of them who couldn't achieve the thing. And the third objective was at least 70% of the 16 TOT supported trainees will attain proficiency in knowledge and skill in utilizing the device. So we achieved about 73%, a little bit above the target. And this is it. Number of learners total was 15. 4 of them couldn't reach the mark, but 11 was able to reach the mark. The next objective was improvement in the process of high-risk obstetric cases reported with POCUS, achieving a statistically significant improvement in the proportion of high-risk obstetric cases reported with POCUS by trainees over time, from the start of the POCUS to the end of the project. This one had this. You realize that almost every month, the trainees were able to do at least about 500, or let's say 500 as average scans. So in total, at the end of September, they were able to do around 3,500 or more scans, and they were able to pick some high-risk pregnancies, which was also a little bit below 500. So we're comparing the proportion of high-risk pregnancies detected during the first 3 months we were training them, and the 5th and 7th month we were training them. These are the figures we got. So month 1 to 3, we were having these figures. And from month 5 to 7, these were the figures we picked. So a paired or dependent t-test was conducted to assess whether the increase over time was statistically significant. I think the p-value got up to 0.045, which was very significant. T was 4.65. So it was statistically significant. This indicates that the proportion of high-risk pregnancies identified in month 5 to 7 was significantly higher than in month 1 to 3, suggesting improved detection performance as trainees gained experience and ongoing mentorship. So graphically, you could see the rate at which they were detecting the high-risk pregnancies, and this is the resultant curve. There was about 59% increase in the proportion of high-risk pregnancies detected in the later months compared to the early implementation period. And this shows that beyond being statistically significant, the improvement was also programmatically meaningful, likely to reflect increased trainee confidence, ongoing mentorship, and all those stuff. Oh. Okay. So the next and the last objective was about to achieve a 75% utilization rate for POCUS devices in relevant obstetric cases indicated. And this was it. So total scans indicated were listed, and total scans that they were able to do at base were also listed. Looking at the utilization, you realize that almost all of them was having a significant figure, which gives us about 94.37 utilization success. Okay. And these are the processes we went through for time's sake. These are pictures they took when they were visited. And this is the in-person training at Buzua, being taught on pregnant women, some of the facilitators. And this is about their OSCE, when they were doing their OSCE at the end of the training. And at the midpoint, they were visited and so many things were done. These are some of the online pictures they took. And this program also had some challenges. One is the gassy up-down time, poor internet connectivity in some of the remote areas that we were trying to do the project. You will call them, you can't even get them. Sometimes they were supposed to send images for you to review and give them comments. You can't even get the images, and they said internet connectivity was a problem. Limited data bundles, road inaccessibility. I think one time we tried to visit Amenfi Central, Manson facility, and the journey was over 12 hours. You can't believe that, yes. And staffing constraints. Some of the facilities that we pick some staff, you realize that the midwives in the facility were only 2. So once you pick them for the POCUS training, you are not getting further midwives for the next training. It was also a problem. So in conclusion, I think POCUS program was well integrated with ingrowing interest and other things. So our recommendations will be maintain app functionality and ensure backlog uploads. And all these things are done. Improve internet access and refill data bundles for the midwives. Provide funds for printing, logistics. Continue mentorship to sustain progress and enthusiasm that we are still doing. These are some of the remarks from the midwives, and these are some of the key points from the report. The 2 cohorts had differed in training modalities, a total of 47 midwives, and so on and so forth. For the lack of time, I would want to end here. Thank you.
Thank you very much, Dr. Frimpong. Quite exciting to see very familiar faces involved in the program. So there will be the question time and time for discussions. So kindly put down your thoughts and your questions as we go along. Okay. So we'll have our next presentation. But before then, I've been informed that the Vice Rector of the Ghana College, it's in the house. Prof. Lawson, if you're here, let's acknowledge you. Okay, there he is. All right. Seated by the faculty chair. Okay, thank you very much. You're welcome. So our next presentation is on acute pain in emergency care, evaluating practices, outcomes, and patient experiences in a tertiary hospital in Ghana. And we have Dr. Med Andara Tuwoni from Konfanoche, right? Good, Konfanoche Teaching Hospital. Let's welcome Dr. Woni. He's a family physician. Great.
Good morning. Just a little correction. I work at a private facility, but at the time the research was being conducted, I was a resident at Konfanoche Teaching Hospital. Okay, all protocols observed, Honorable Chairperson, colleagues and guests. It's an honor to be here today to present on a research that was conducted at Konfanoche Teaching Hospital, where we evaluated the practices, outcomes, and patient experiences So this research was conducted over an 8-month period, and we conducted it across the 3 emergency service delivery points in Konfanochi Teaching Hospital, i.e. the adult emergency, the pediatric emergency, as well as the family medicine department. All right, so globally, pain is one of the most prevalent presenting complaints at emergency departments, accounting for about 78% of all ED visits. However, with guidelines and improved emergency care, there are still certain gaps that we need to breach. In Ghana, the sociocultural context and then providers' experiences is shaping how we evaluate and then manage acute pain. Our research, therefore, had 2 main objectives. That is to describe how patients 12 years and above presenting with acute pain across the 3 emergency departments were managed. Importantly, we also wanted to assess patient satisfaction. So we wanted to measure patient satisfaction with acute pain, evaluation, and treatment at the time of ED all the way to discharge. So this was a prospective cross-sectional observational study, and the population was mainly patients 12 years and above with acute pain of any cause. Data was standardized using trained research assistants and captured in a REDCap database. So we explored the biodata, the treatment timing, medication, the pain profile. We also wanted to assess how patients was assessed at the time of presentation, as well as the care timelines, and then also the patient's level of satisfaction. So 340 patients met the inclusion criteria. Our participants were predominantly young male and of working age. And most of them fell within the age bracket of 19 to 40 years. And most of them were students or unemployed, followed by artisans. All right, so a majority of them were referred from other facilities. And even more so, most of them had received pre-ED analgesia before presenting to Konfanochi Teaching Hospital. So pain was formally assessed in about 88% of these patients. However, less than half had the pain assessed using a standardized pain treatment tool. Sorry, I can't see my slides very well. Okay, and for those who were assessed with the tool, the numeric scale came up overwhelmingly high. One key thing we noticed in this research was that most of the initial assessments were nurse-based. So nurses led the first assessment, up to about 69% were initiated by nurses. All right, at the time of admission, about 3/4 of the patients had severe pain. But if you look at the other corresponding diagram, you see that IVP more predominated the medications that were being used. This is a potential gap issue. 42.9% were discharged home. Some were lost at the ED. And interestingly, most patients had satisfaction with pain evaluation as well as pain treatment, up to about 92%. Within 10 minutes of presenting to the emergency department, most patients had been assessed formally for pain. Okay. However, by the time that they had their first analgesia, it took up to an hour before first analgesia was given. And this definitely falls below the international benchmark, about 2 to 3 times more the time, the international benchmark for managing acute pain, if you look at the pain pathway. So the strongest independent predictor of satisfaction with both pain evaluation and pain treatment was residual pain at discharge. That means that patients who had residual pain at discharge were less likely to report satisfaction with pain management and pain evaluation. Also, age and then time to pain evaluation were also strong predictors for satisfaction and then pain evaluation. As with every observational study, there are some limitations. The fact that it is this limits our ability to establish a strong causal inference. Also, it was a single site study, and so we cannot say that we can extrapolate it or generalize it to other facilities. Okay, we also have recall and desirability bias, especially in our sociocultural context, where there's reluctance to give negative feedback. Also, there's a strong confounder in that most patients had received analgesia before getting to us. And so that could have altered certain variables. All right, so in summary, pain is recognized early in Confanochi Teaching Hospital. However, there are gaps in that patients are not assessed by using standardized pain treatment tools. Also, reassessment was a challenge. If you look at the current WHO pain ladder and the corresponding methods, it's not only by mouth, by pain score, by the ladder, okay? Now we want to individualize it for the patients, and also attention to detail, which would include you managing side effects as well as reassessing to see if the patient is responding. There was also analgesia delay where patients were managed within 10 minutes. However, it took up to 60 minutes for the first dose of analgesia to be given. And interestingly, there was high satisfaction in terms of pain evaluation and then pain management in Confanochi Teaching Hospital with this study. All right, so what we found obviously is actionable. And so we have a few recommendations here. We noticed that most of them were nurse-based assessments. Most of the patients had their assessments by nurses to begin with. So we can empower the nurses, protocolize pain care, and then nurses can do a lot more instead of waiting for the patients. We can look at locally validated triage pain scales, structured pain reassessment protocols, quality improvement and audit cycles, training and capacity building, and of course, more research into this. One striking thing about our research is the fact that we could barely find data that made pain patient-centered, where patients were assessed about how they experience their pain, necessarily feedback on how they experience their pain. So I think this is an area that needs to be explored further in the future. Okay, so I have no conflicting interests to declare at this point. Thank you so much for your attention.
Thank you, Dr. Wuni, for the interesting study. I'm sure we'll have some questions to ask and some contributions to make as well. Good, thank you. So we are moving on. Is everybody going along with me? Those are the fine. Usually in class, I'm interested in those at the back. I want to make sure everyone is paying attention. So I usually do question to those at the back to make sure they are alive and well. Okay, so let's go on to the next presentation by one of our sponsors, by Novo Nordics. So the representative, yes, let's welcome the rep. Thank you.
Thank you, everybody. Good morning. I'm Mr. Sumi Brimpo, and I work with Novo Nordisk. So this is just Novo Nordisk at a glance. So the glucose triad. Are we overlooking postprandial glucose control? What is the glucose triad? Okay. So the glucose triad, we have seen in past times that most of the time, healthcare practitioners tend to focus more on the fasting blood glucose or fasting plasma glucose. And with time, what we realized is that eventually the patients may not meet their glycemic targets. And so what we normally would do is that we'll look at fasting plasma glucose, we'll look at A1C, and then we'll just settle on that. But we have realized that it is very imperative that we as healthcare practitioners try as much as possible to also focus also on the postprandial glucose. Why? Because postprandial glucose tends to be an independent risk factor to most of our non-communicable diseases. And so when we are treating our patients, we always want to look at how we can treat them holistically, looking at both the postprandial, the fasting plasma, as well as the A1C. So with targeting the fasting plasma glucose, the postprandial, as well as the A1C, we are looking at modern insulins. Now, modern insulins have come to stay, and we want to look at some of their attributes. What makes modern insulin so unique is that in terms of their efficacy, there is very good A1C control. In terms of their safety, the lower risk of hypoglycemia, and then in terms of their pharmacokinetic and pharmacodynamic properties, it helps with convenience, and it also helps with treatment flexibility. Now we are looking at Novomix FlexPen. What is the Novomix FlexPen? Now Novomix is a combination of 30% insulin aspart and then 17% protamine crystallized insulin aspart. It's used to treat diabetes mellitus in adults, in adolescents, and children aged 10 years and above. For its pharmacokinetic properties as compared to biphasic human insulin, popularly known as Mixtard, for Novomix 30, the good thing for our patients is that when you inject it, its onset of action is between 10 to 20 minutes, meaning that your patient don't have to inject 30 minutes before they eat, right? Now, when it comes to peak, it also peaks immediately between 1 to 4 hours as compared to Mixtard, which normally peaks between 2 to 8 hours. And then in terms of its duration of action, it's actually able to last for the 24 hours. This is what makes Novomix 30 very unique. Now looking at the profile and comparing Novomix 30 to physiologic insulin, the deep blue line is Novomix 30, the brown line is Mixtard, yes. So in terms of flexibility, injection flexibility, as I mentioned before, immediately you inject it, it peaks. So as compared to Mixtard 30, you realize that it peaks immediately. And so within that 1 to 4 hours, it will be working. The 30% arm will be working. And then it troughs also immediately. Now, the way it's able to peak and trough immediately helps with a better postprandial glucose lowering effect as compared to Mixtard, which normally will not peak immediately. You also have to inject 30 minutes before your meals, and then it also takes a longer time to trough, and it keeps on lingering. And because of this shoulder effect, most patients are predisposed to hypoglycemia. Now, with Novomix 30 comes that 24-hour, duration of action, as I mentioned. And the good thing about Novomix 30 also is that you don't have to do it immediately when you are initiating Novomix 30. You don't have to do twice a day, 2/3, 1/3 that we normally do. You can do once a day injection, 2 times, and then intensify even to 3 times. Now let's look at how we start once a day Novomix 30. With initiation, once a day, you do 10 to 12 units pre-dinner. Then what you do is that you adjust those every 3 to 7 days to reach your fasting plasma glucose targets. And then you also look at your A1C after 3 months. After 3 months, if the A1C is 7% or less, you maintain the dose or repeat the A1C after 3 months. But if it is more than 7%, what you do is that you move on to the second insulin injection. Now with insulin twice a day, what you now do is that you give Novomix 30 at 5 to 10 units twice a day. And then for every 3 to 7 days, you also would adjust the pre-dinner and the pre-breakfast targets based on what you have decided with your patient. After 3 months, you now look at the A1C. If A1C is 7% or less, you maintain the dose and then repeat A1C after 3 months. If it is more than 7%, you intensify to the next step. Now, this is the beauty of Novomix 30. the intensification of twice a day premix. What we've seen is that for Mixtard, as you increase the dose, the patient is going more into hypoglycemia. Some patients are also insulin or hypoglycemic unaware, and then with an increased dose of Mixtard, normally some patients who are on, let's say, 60 units, 70 units, or even more of that, normally will develop insulin resistance. This is something we also want to avoid. So with that 3 days intensification, what we do is that we do titration of morning dose 2 to 4 units, which may be needed. We adjust the doses, preferably once a week, according to the algorithm. Then we continue with any OAD that the patient is on. Then we consider discontinuing any form of thiazolidine dione that the patient may also be on, according to practice and local guidelines. And then, as usual, after 3 months, if the A1C is 7% or less, we stay on that dose, and then what we do is we repeat the A1C again after another 3 months. But if the A1C is still high, what we do is we check all postprandial levels. So this is how our Novomix 30 Flex Pen looks. Now, all our insulin are color-coded, both the vials and the Flex Pens. Now, this is exactly how Novomix 30 looks. It's a pre-filled pen device, no need to load a cartridge, soft touch to deliver insulin, which is less injection force, and minimal pain for microfine needles. Accurate dosing is enhanced by dose selector and display monitor, can store at room temperature after 1 use, and no need to store in the fridge after the first use. What does this mean for our patient? Because of how our insulin devices are manufactured, once you inject, if a patient, peradventure a patient needs about 2 Flex Pens for the month. Once they inject the first dose from one of the pens, they don't have to put it back in the fridge. This means that your patients can walk around, move around, travel around, so far as they know the time they're supposed to inject their insulins. Because of how flexible it is with our Flex Pens, they don't have to put it back in the fridge. They can always inject between 25 to 30 degrees Celsius. They are fine. So this is our insulin portfolio brand. Okay, sorry. This is our brands. We have the NovoRapid, we have the Novomix, and we have the Tresiba. Our NovoRapid is our fast-acting or rapid-acting soluble insulin. It's fast-acting, which is normally used to augment intensification with our basal insulins. Then we have the Novomix 30, and then we have our Tresiba. Our Tresiba is our ultra long acting basal insulin that you can equally use with our NovoRapid. Thank you very much for your time and your attention.
Thank you very much for this presentation. I hope of this information flow so that it would help in our practice. I think we have the next presentation also by scientific session. All right. Okay. Thank you very much. All right. Good. So we have Dr. Medrena M. Pele. Dr. Pele is a family physician from Tamale Teaching Hospital, and she's going to present to us on the endorsement of redesign of adolescent health services in a primary care facility in northern Ghana. Let's put our hands together and welcome Dr. Pele. Good.
Thank you very much. It's an honor to be part of those presenting our abstracts today. I think they are trying to. All right, thank you. Okay, so um, the title of the presentation is, I know this title looks a bit weird or funny, but then you'd get to understand along the way. The title of the presentation is, This Your Initiative is Good. It is going to help many young people. With the main title being Endorsement of Redesign of Adolescent Health Services in Private Care Facility in the Northern Region of Ghana. And my name is Rina. Okay, so this study was done among a group of people known as the adolescents and young adults, which is usually between the ages of 10 to 24 years. And this group of people obviously belong to a wider range of a community, which is the families that they belong to. They are usually not unable to make decisions for themselves, so they are usually under their guardian or under their parents who make decisions for them. It was realized that in the northern region, most of these young adults, as we know, who have a lot of problems or issues within their lives and are unable to open up to people around them, come for consultations and are generally not able to tell us what is actually going on with them. And so we see a high rise in certain risky behaviors, especially in the northern region, such as illicit sex and alcohol intake and all that. And so we decided to run this particular study. This group of people, as I said, are under a wider community, which is the family or the guardian. Now, these families make decisions for them in terms of their health, in terms of health decisions like certain services or uptake of certain services and utilization of these services. Now, some of these communities or some of these families, which we know, we have the patriarchal system and then the matriarchal system. What is dominant within Ghana or in sub-Saharan Africa and Ghana is the patriarchal system, where the patriarch, which is the male figure, makes decisions within the family. And most of the time, these leaders do not have a better understanding of these services. And so they make decisions to prevent them from having access to some of these services, such as the adolescents and reproductive care services. And so they are exempted from having access to some of these services. These same patriarchal communities as well also have a lack of understanding of the transition of these young adults from these people from the mid-adolescence to the young adult stage, where most of the time they are prone to having where they want to be autonomous and want to make their own decisions. And so this causes conflicts usually within the family, and hence it causes these young I'll call them AYAs, having issues with them. Now, coming to the clinical setting, during consultations, because of some of the secretive lifestyle of these AYAs, it is very imperative to try to get information from them. But because of the presence of their guardian or the presence of their parents during these consultations, they are unable to open up and tell us what is actually going on. Privacy, confidentiality is something that is very important during these consultations, but then they are not given because the guardian or the parents want to be present within these consultations. And hence, we as Curious Doctors decided to set to have a redesign of this consultation services for these young adults, where they would have more privacy during the consultation. But in order to have this ongoing, we realized that the design should be from the perspective of the AYA and the guardian, in a sense that we wanted to explore how they felt the service should be done so that they would utilize the service. And also we wanted to ensure that this service should be accepted within that particular culture. That's the patriarchal culture or the patriarchal community. And so the services The services should include private one-on-one consultation with doctors, confidence space to discuss their sensitive health risk, consultations that go beyond their complaints, and then careful guardian involvement when needed. And this was going to be from the this is a framework, but then using the perspective of the family system theorem, the socioecological model, the patient engagement, and the general systems theorem, which includes the environment of the AYA. And hence, we came out with an objective, which is to understand the participants' perception of care that embraces these aspects with the intention of incorporating their views into the redesign of the services within the Tamale Teaching Hospital. So the study that was conducted is a qualitative study, which we use in-depth interviews. It was done within the Tamale Teaching Hospital in 2024, and it included, participants included 12 AYAs, as the adolescents and young adults, and 8 guardians who were recruited around as they came for consultation. The data was handled, we used interview records and was transcribed and then coded using the in vivo 14 with analysis done using thematic analysis and reporting using the correct guarded qualities. Now, each AYA, the criteria for them to be chosen for this study was that they should have had at least 1 visit within a year to the polyclinic, and then also their guardian who was included in the study should have also accompanied the AYA to the facility in the past 1 year. The age range of the AYA was from 14 to 24. The sex was 1:1.5, and the guardian was 4. We had 4 males and 4 females, and then the guardian age range of 32 to 64 years. This sampling was deliberate in such a way that, knowing very well that the guardian and the AYA come from the same house, looking at the perspective of the family system theory, where we're looking at the structure, they are basically would have the same ideology or the same views of things. So we wanted a balance in terms of the ideology and then what they think. So it wasn't a 1:1, as in 1 AYA and their guardian that was used for the study. Now, the analysis of it, we try to incorporate the Baron and Clark approach, which is the 6-step approach, which is the familiarization, coding, theme search, theme review, define name, and then reports. Now, we also did it from the perspective of, so these were the 6 themes that were emerged as the result of the study we did. We looked at autonomy and confidentiality, psychological safety in the clinical space, unmet and hidden needs, role of parents and guardians, their facility level barriers, and implementation. Now, in the first one, which is autonomy and confidentiality, when being asked, most of the AYA indicated that they would prefer a consultation where it's one-on-one with only them and the caregiver, because they sometimes are not comfortable having their parents being present during consultations. Hence, they're unable to open up to tell us what is actually going on with them. And then some of the guardians also bought the idea. They got to understand that, yes, in the presence of them, the AYA are unable to express themselves, while a few of them did still insisted that they actually wanted to be present during consultations. Now, in the second one, which was the psychological safety in the clinical space, we were trying to explore how comfortable they will be during consultations, because sometimes you can have the one-on-one consultations, but then when, depending on the caregiver's demeanor or caregiver's tone and things that are said, hurtful things that are said to them, they will be unable to open up. So one AYA says that from the demeanor of the doctor, I didn't feel like it's something I should bring up. The third one is the unmet and hidden needs of the AYA. Sometimes they express that they come with their presenting complaint, but then they have other things that they want to be spoken about, but the healthcare provider is unable to explore such areas, so they're unable to meet the needs of them. The fourth theme was the role of parents and guardians in the decision making. Even though there is advocacy for privacy, confidentiality, and autonomy, the parents is also still important in making decisions for the AYA. the whole idea is not to exclude the parent totally from the consultation, but that there should be agreements that the AYA should have some little confidentiality, but then they will still be part of making decisions. Some of the AYA agree to that aspect. The fifth theme being the health facility level barriers. Some of them expressed the fact that the high pressure within the facility and then continuity of gaps, that's continuity of care, where they would have to be seen by a different caregiver, affects them opening up because they are not able to open up to one health caregiver and then the next day they are opening up to another health caregiver. And space constraint as well, where sometimes within the consulting room it's probably shared, and so they are very conscious about the information they are giving out. Whoever will be listening to whatever is being said. So as we see by AYA 12, she said that too many patients and then they are in a hurry, and then says that they can't come back when I see a different person. The last theme, which is the implementation reference and strategies, they actually explain that it will be better if this becomes a policy within the facility, where the guardian is made to understand that when they are coming to the facility with their ward, they should be made to understand that the consultation would include them having privacy together. That's the consultation would include a one-on-one consultation between the health caregiver and then the AYA. And so they said that it should employ, they explain the protocol to the AYA and then the guardian before consultation begins. And whilst consultation is ongoing, if the guardian is required to come in or to be involved, they will be informed and then they come in, of course with the permission from the AYA. So generally, in conclusion for this study, the whole idea is not that the patient, it's not that the guardian or the parents will not be included within the consultation, but then to make enough room to allow the AYA to express themselves and be able to see what is actually going on with them. Privacy protection, where we make one-on-one consultation routine, not awkward and ad hoc, respecting of boundaries, where it is explained very well to the patients and then to the guardian, and then the youth and guardian preferences to shape the actual work. All right, so this is the key framework that was used, and these are the references that was used for the study. Thank you.
Thank you very much. I believe we're coming to the end of. Do we have? All right, okay. So we'll do one more presentation from our sponsors, and then we'll have a period. So let's welcome the rep from Mega. Okay, thank you.
Good morning, everyone. Are we excited like the way I'm excited? I know anytime we hear mega presentations, oh, someone has already taken her phone. Anytime we hear mega presentations, everyone is eager. So today promises to be a very exciting one, just like all other days. There are very beautiful gifts to be won today. I didn't introduce myself, forgive me. I was so excited like the way you were. My name is Renee Afonyako from Mega Life Sciences. I think we'll have to control from the back. Yeah. Okay, so at Mega, we have three main objectives. We care about your health. We want to promote human wellness. And finally, we are the parent's guardian when it comes to your health care. These are the three main objectives from Mega Life Sciences. And today, we want to look at a different way of having our presentation. So please, if you have your phones, your tablets, please just scan the code you see on the screen or log on to www.menti.com, enter the respective code. Let's get started. Today's only, because it looks like use the presentation, we'll use speed to determine our winners today. Do you agree with me? So please scan the code or go on to www.menti.com, log on to the code, and then let's get started. Please, are we ready? Are we ready? Should we give some few more seconds? Hey, I hear a lot of people saying no. You know this game actually tests the type of network provider you have. If you don't have a good network provider, I'm sorry, today you will lose. Can we start? We are good to go. So please, let's get started. To our first question. Wow, I have so many players. That's beautiful. Can we start now? A few more minutes or seconds. Are we ready? A lot are joining. Okay. I want it to be fair so that someone doesn't say, I couldn't log on, so it's not fair that I couldn't log on and someone logged on faster. The code. So please, someone wants the code, so can we just go back so that they can get the code, please? Okay, so the code is back. Thank you. Thank you. Let's get started. Question 1. Are we ready? Are you anxious? Okay. The question. Time up. Okay. Let's see who the winners are. Okay. Okay, so the correct answer was GoFix. GoFix is a brand of ibuprofen on the market. It comes as a solubilized ibuprofen and it uses the clear cap technology. This allows us to have a much faster onset of action, giving us a much more greater bioavailability and faster pain relief from your joint pains, from your muscular pains, from your period pains, and all types of pain. The dosage for adults and children 12 years and above is 1 capsule 3 times daily after meals. Let's see who the winners are for this question. If you see your name at the top, please give me a wave. Please give me a wave if you see your name at the top. Okay. Who is Miss M? Who is Miss M?
So Miss M is leading.
Okay, Miss M is at the back. I've seen Miss M. Beautiful. On to the next question 2.
So get ready for the next question.
Question 2. Are we ready? All right.
Question is coming. What is the respective dose of avalin citrate and simeticone in avalin?
I know. This one I decided to do that.
You have 10 seconds to go. Fastest finger. We don't know.
Time up.
Yeah.
Okay. Oh wow. Oh, that's nice. So some people still got it. The next one, please. The next slide.
let's see the
So
answer.
Alvarin is our brand of Alvarin citrate and simethicone combination on the market. Alvarin citrate is our antispasmodic for all your muscle cramps. And then the simethicone is our anti-flatulence agent to help you with your bloating, your excess gases. The dose for Alvarin is 1 capsule 3 times daily. It is effective in your irritable bowel syndrome, in your peptic ulcers, in your dysmenorrhea cases, amongst other conditions. Next question, please.
So we'll see the.
So let's see our winners. Don't tell me Miss M is still on the leaderboard. Miss M. Okay, there's a change. So who is Softball? Okay. Okay. The next question.
Question is coming.
Question 3.
Oh,
I think you've skipped it.
I think there was a mistake somewhere. Okay. So we'll go to question 4.
So question 4. Okay.
Oh,
Oh,
I think the.
what's happening today? What's happening today? What's happening today?
It's the internet too. Hold on a bit.
Ay. Okay, so question 3.
These are bonus questions.
You have to guess.
So 24 has.
Okay. But I think we did well. So Nomagat is our freeze-dried yeast-based probiotic. It contains Saccharomyces boulardii. So, we are entering a different trend where people are embracing probiotics. Probiotics are relevant for all forms of conditions. Specifically for Nomagat, in your diarrhea cases, your viral diarrhea, your traveler's diarrhea, any type of diarrhea, we recommend Nomagat for both children and adults. One would ask, how do you give Nomagat to a child? For children, it is 1 capsule, open the shell, mixed with either their water or juice daily. And then for adults, it's 1 capsule twice daily. Can we see who our winners are for this question? I know this one was a little difficult, but some people still got it. Faba. Who is Faba? Who is Faba? Who is Faba? You shouldn't worry. Okay, I think I know who Faba is. Next question. Question 4.
Get ready. The question.
Question 4 is ready. This one, there was apokonkron for this question. Wow, very good. So Nuts B is our vitamin B complex containing folic acid, biotin, inositol to help with all forms of neuropathy. So in the diabetic clinic, you realize that Nuts B will be the most common product that is prescribed. But apart from diabetic neuropathy, in any form of peripheral neuropathy, Nuts B is there to also help your patient. The next question. So who is our leader for this question? Faba? It's still Faba. Well done, Faba. Next question. Beautiful, beautiful, beautiful. Round of applause for everybody. Beautiful. Thank you. So Livolin Forte is our hepatotonic, our hepatoprotector on the market, which helps in replenishing damaged liver cells. So in your non-alcoholic fatty liver disease, your alcoholic fatty liver disease, your viral hepatitis, we recommend Livolin Forte for your patients. The dose is 1 to 2 capsules 3 times daily. We realize from surveys that most people do a 1 daily dosing for Livolin Forte. It is actually a dosing problem out there. So we want to correct it from today. The dose for Livolin Forte is 1 to 2 capsules 3 times daily. Can we see who our winners are? Faba. Faba. Who is Faba? Who is Faba? The person doesn't want to raise his or her hand. Our next question. We are getting to the end. So if you still find yourself at the bottom of that leaderboard, it means that you need to really up your game in the next questions. The network. Thank you, Limza. So Limza is a combination of our omeprazole and then our sustained release domperidone for your severe GERD, your NED, and then your dyspepsia. The dose is 1 capsule daily, 30 minutes before food. Can we see who our winners are? You'll be surprised. Hey. Okay. Okay, next question. Next question. So we have 2 more questions, this and the last one. Ready? The clue to this question, all women should get this question right. All the women here should get this question right. Inat. Can we move on to the next slide? So Inat is our vitamin E on the market. The active ingredients is our D-alpha tocopherol, which helps in replenishing your skin, boosting your immune system. It also helps in reducing any form of pain when it comes to your dysmenorrhea as well. Can we see who our winners are? Is Faba standing behind my laptop? Because I don't understand. Is Faba standing behind my laptop there? So the last question for today's session. Okay. Another clue to this one. All men should get this question right. Okay. Very, 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 very good. Thank you all for participating. Ginseng is our ginseng extract. It contains our Korean Panax ginseng. It has multivitamins and minerals in there to help boost your sexual performance for our men. It also helps to give you energy. It helps to reduce fatigue, stress, and it also improves your overall well-being. So recommend that all our men here, after this meeting, please go out there and get a pack of ginseng from our stand. This is highly recommendable. Thank you all. So at the end of today's presentation, I think we'll have to give some awards to our top 5. So if you hear your name, who is Faba? Now Faba has to come out. Okay, so Faba was near my laptop. So we have some gifts we want to give our top 5 winners. So Faba can come, Trine can come, Sue, I hope I mentioned your name right, Miss M, and then Nadi. Nadi. A round of applause for them as they come forward. Mr. Faba, so because you topped, for today's session, you are going to get 2 gifts instead of 1 gift. Thank you so much. All right. So 2 gifts.
Thank you very much, Mega Life Sciences. A round of applause for them. That was great. Okay, so we'll now have a very brief session. I would like to invite the presenters for the 3 oral presentations. Dr. Osei Frimpong, Dr. Andaratu Wuni, and then Dr. Arena. Please come up the podium.
Hello.
And then we'll have brief discussions. Thank you.
Hello. 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 Hello.
Please, shall we all be seated? Let's finish with this, then we can have a short break, and then we. Okay, so we've had 3 very exciting presentations. One from Dr. Osei Frimpong on emergency obstetrics, focused on emergency obstetrics. Then we also had one in acute pain emergency care, and then the redesigning of adolescent health services in the primary care. So please,
Hello.
we would like to have some discussions. If you have a question for any of the presenters, kindly put up your hand, and a microphone will be brought to you. A question or a contribution or any comment that you have. So, yes, Dr. Aglobe.
Thank you very much, all presenters. My comment goes to Andaratu. To what extent does perception of pain in Ghanaians affect what your study? For example, some people think that some pain is good and you don't want to kill all the pain. And I've heard that several times where we feel that we have to experience a minimum amount of pain. So even in palliative cases, when you want to get the patient very comfortable, people are not very comfortable giving the adequate analgesics too. I was saying to what extent does perception of pain in our context, our Ghanaian context, affect or influence your findings? For example, as I was saying, some people feel that you have to experience some pain, and so they are not very comfortable. So physicians on one side are not very comfortable giving the adequate doses of medication to adequately control pain. And then some patients may also not feel that they need to have complete cessation of their pain. So to what extent does the fact that we Ghanaians, that's my context, influence what your results were in that study? Thank you very much.
Okay. No.
Hello.
Can we get a bit of volume for the microphones, please?
Okay, thank you for the question, Dr. Dora. I would approach this by talking about how, even though there were lapses, obvious lapses, in pain assessment and pain treatment, we still had a high probability of, we still had high patient satisfaction. You would expect that with such, the patient satisfaction would be somewhat or very, very low. So definitely this question comes into play here in the sense that patients in low to middle income countries would have lower expectations because our setting has a lot of issues in terms of management, patient management in totality, not just with pain. And so somebody who comes with pain, of a pain score of like 10, and then is given medication, pain score comes to 7. Because of what I have just discussed, there is the tendency to report satisfaction, but is that optimal? Absolutely not. So yes, that would come into play here. Considering that we had high patient satisfaction, even though there were obvious and then serious lapses. During data collection, sometimes we went through with the research assistants. We didn't really get patients that felt like they should be in pain. I guess that's why they came to the ED. Okay, they knew that they wanted pain relief. And from these findings also, we found that residual pain at discharge was one of the predictors of pain dissatisfaction. So in that sense, you wouldn't say that patients want to be in pain. Okay, but of course, your point is really, really important here. And I think that is shown in the patient satisfaction, even though there were lapses in management. Thank you.
Yeah, thank you very much. Any other questions or contributions, comments? Okay, there's one there. Kindly introduce yourself, and then you ask your question or give your comments. Thank you.
Thank you for the presentation. My name is Salamatu.
Microphones, please. Yeah. All right. Thank you.
Thank you very much. My name is Salamatu Atanan Tokma. My question is, and thank you for the presentations. And I just wanted to ask a question on the POCUS. Very interesting outcomes from the pilot that was conducted. I just wanted to find out, based on the results that have been achieved and the fact that it's been able to give us very good outcomes, what is the plan for maintenance of these tools in those facilities, and also any sustainability plan for rollout or for ensuring that this can continue? Does Suffolk plan to continue supporting them and all that thing?
Okay. You can take that.
Okay, thanks for the question.
Yes, it's
When it comes to sustainability plans, I think initially I was told I had 10 minutes, so I had to rush. But at the latter ends of the presentation, you will realize that we had a lot of discussion after the program. And the issues that came up included, should we allow the midwives to charge a token so that they can save those monies, and when the machine is faulty, they can use it to prepare, or maybe they can even procure a new one. And the issue was that Ghana Health Service, you can't do that. We have free maternal services and others. So you cannot charge at the local level. Maybe we have to inform the policy makers to put it in so that they can charge. So it's still a gray area that I think the discussions are still ongoing as to how to replace the machines when they get faulty or when they are spoiled, and how to also sustain all the consumables and other things we use in doing the POCUS. I think it's still a gray area. I don't know if Dr. Nketia and Dr. Baba can help, but it's still a challenge.
Okay. Yes, another person. All right.
Yeah, thank you. The POCUS.
Please introduce yourself.
Yes, my name is Okansi, John Okansi, yes. Does it do Dopplers? Does it do Dopplers? I mean, yeah, Doppler. Sorry?
You mean the scan, that's what?
Can it do Dopplers?
Doppler.
Doppler. Ah, okay. If you have the skill, it can do Doppler. Yes, because it has the color listing on it. So if you have the skill, you can use it to do Doppler.
Thank you.
All right. Okay. Any other person, the question, and then maybe we'll take the last one, then I'll ask my questions.
All right, thank you. I'm Emmanuel Cheneboa.
All right.
My question is to Dr. Wuni. So I wanted to find out, the study was conducted across 3 different emergencies: the adult emergency, pediatric emergency, and the family medicine unit. So was there any significant difference in terms of pain assessment, management in the various disciplines? Whether there was any significant difference in the pain assessment, whether maybe family physicians were able to attend to patients' pain maybe better within the recommended timelines compared to the other departments, or vice versa?
I think that's a very interesting angle and a very interesting dynamic. Truly, that wasn't the CRASC. That was not the CRASC of what we were trying to achieve with this study. However, I feel like it is a major point for future research opportunities. Yes, thank you.
Okay, so your question has had to do with how the different maybe practitioners or specialties, their approach to handling of pain. All right, okay, that's a good one. Okay, the last, your name and then your question or contribution.
Sylvester Danso, TTH. My question is to Dr. Pelly. You started with an interesting title. So I was hoping by your conclusion, you go back to the title to explain why that interesting title. If you can please elaborate further. Thank you.
Okay, so the study was a qualitative study, and as I said, was done in the Tamil Teaching Hospital. So that quote was taken out of what one of the AYAs said. Usually that was under the theme confidentiality and then autonomy. So it was the AYA trying to express that whatever redesign that we wanted to do was very good, and that it was a good initiative that would help the AYAs be able to express themselves and then open up during consultations.
Okay, thank you very much. You have a question? Okay, I'll grant you that one.
Thank you. My name is Famous Anonso Itama Teaching Hospital. My question is on POCUS. I want to find out, do these trained midwives do the scan and make decisions based on those scans immediately, or they have to send the images for the mentors to review, give them feedback for a decision now to be taken? If it's the latter, then doesn't that cause some delays because it's emergency service? Thank you.
Okay, so I think that was a question. Okay.
It's a question. So, thanks for the question. The midwives, as I told you, were taken through a rigorous training. And even after the in-person training, they were supposed to be mentored online. So they were sending images to experts, or we call them mentors, to review the images and give them comments for them to go ahead and scan. You realize they did a lot of scannings. And even after the project, they are still scanning and sending it to the mentors. What the belief is that they should be able to do good imaging with minimal comments before we can allow them to scan on their own. Apart from that, they are supposed to always be dealing with their mentors. Sometimes too, when they do the scan and they are not too sure, we advise that they go to a professional sonographer to do it and give the comments, especially if it's not an emergency. But in emergency situations, when they get it and they deal with their mentors online, they should be able to act on the situation. As I told you, some of the facilities were as far as 3-4 hours to a nearest sonographic area that they can go and scan formally. Some of them might even have abortions and other things on the way. So the comments, last part of the presentation, the comments about from the midwives, if I had taken my time to go through, you marvel. They were so happy these things were with them. Their ANC numbers were increasing rapidly up because most of the pregnant women realized they could do it. So they are still under mentorship. It will come to a time that will allow them to do it on their own. Thank you.
Okay, thank you very much. Just a few points. Dr. Pele, the age group of your participants between 10 to 24, am I right? 10 to 14. Oh, okay. Because I thought your definition of an adolescent crossed the 18 years. So I was going to ask you about someone being 18 years independent, still be under the parents' roof, and how you're going to manage their level of independence from that point of view and from the parents' point of view. But if it's 10 to 14, then that's okay. Yeah, that's okay. Thank you very much. But how different are your findings from the current practices? You said you are redesigning the adolescent health services. How is it different? Your find how is it different from the current practice?
So the difference was that because these are young adults or these are adolescents, during consultation, the guardian or the parents are usually present during consultation. And so they are unable to express themselves or say the actual problems or issues that are happening around them. So with this new design, we advocate that the guardian or the parents are educated about the fact that that particular session will be a one-on-one between the AYA and the consultant and the caregiver until maybe the parent or the guardian is needed to be present in the consultant, just to create room so that they can express themselves and tell us actually what is going on with them.
Okay. All right. Thank you very much. I particularly liked your theoretical framework, how you spoke about the systems there, but we won't go into that for now. Dr. Andra Tuwoni, the nurses use some standardized tools for assessing pain, am I right? The nurses, the way how did they assess the tool? They use standardized, what tools did they use to assess the pain?
Okay, so I did reiterate that majority of the patients were assessed for pain in one way or the other. Some of them, most of them were not used, most of them did not use standardized pain assessment tools to assess the pain. So most of the time it was a Q&A where a patient comes, sometimes in relation to the type of injury or presentation that the patient is coming with. I think that underscores the subjectivity and the issues that we felt we needed to unveil here. So some pain medication were given because at the end of the day, there was some assessment. However, a majority of them were not assessed using a standardized tool that would tell you, quantify the pain and then, you know, reassessment. So there was some assessment in terms of Q&A, the nurses using their own discretion, if you would say. Maybe an RTA patient comes with a gaping wound, you would know that this patient has pain. But then upon Q&A with the patient, you would be able to tell the patient has pain, but was it quantified? No. And so there was no commensurate intervention that matched that. And I feel like that came out in the data eventually. Thank you.
Thank you very much. So you want to go back and maybe train the nurses to use a standardized tool for assessments, okay, and then also administer maybe the initial administration of medications according to the WHO ladder. Then you can compare across. Then the question that came in as to the different approaches to pain management by the different specialties will become relevant. Also look at the psychosocial aspects of pain relief or not. Okay, so thank you very much for that. So ladies and gentlemen, well, my last question to Simon, this, were you, is there any collaboration between you and the obstetricians and gynecologists in this?
Not really. I don't know, but when it comes to the sonographic findings, we least thought about them. So it was just the midwives, the trainers,
Yes.
the experts from the US, and the financiers.
Okay, thank you very much. I think it's very important that we collaborate within the space of primary care. So ladies and gentlemen, I think we've had a very interesting session this morning with our workshops. I think Suffolk, you've been, the message is clear. You need to adopt appropriate devices and apps, you know, that we can use for training, for service, and for research. And that's very important for us to do. It's very interesting that despite the fact that we train a lot of obstetricians and gynecology, we still tend to have a high level of maternal mortality. And that's caused the fact that family physicians need to collaborate with our colleagues in obstetrics and gynecology to stem, you know, that tide. And I want to thank you all, Dr. Pele, Dr. Frimpong, and Dr. Wune for this wonderful presentation. Shall we all give them a round of applause? So we'll have on the program, we have 20 minutes break. I'm going to use my discretion to reduce the time. Please, because of the AGSM, let's make sure we finish on time. So 10 minutes, tea break, just stretch, pick something, and then quickly come back so that we can continue the second session. Thank you very much. Mhm.
All right, please, as you move out, please see the treasurer to settle all bills if you've written your name to go on a health tour tomorrow and you haven't paid, it's really hindering our progress. So sort out those payments. And also you can also pay your dues with her now at the back of the table. Thank you.
Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takora Day. Congratulations. Your theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the community. Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takoradi. Congratulations. Your theme, strengthening primary health care through compassionate innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the communities and on the front lines. I'm also excited that your theme is looking at compassion and digital innovation. These are going to be critical and will help to bridge the gap and help to improve access to children across the various communities, especially within the underserved areas. Now, on a lighter note, I know many of you family physicians are actually pediatricians at heart, and so we are happy to join you today as you deliberate on these very important issues. Thank you for the invitation, and we wish you the very best in this conference. We look forward to continuing to work with you and to partner on improving access to children across the country. Thank you. Bye-bye. Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takoradi. Congratulations. Your theme, strengthening primary health care through compassion and digital innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the communities and on the front lines. I'm also excited that your theme is looking at compassion and digital innovation. These are going to be critical and will help to bridge the gap and help to improve access to children across the various communities, especially within the underserved areas. Now, on a lighter note, I know many of you family physicians are actually pediatricians at heart, and so we are happy to join you today as you deliberate on these very important issues. Thank you for the invitation, and we wish you the very best in this conference. We look forward to continuing to work with you and to partner on improving access to children across the country. Thank you. Bye-bye. Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takoradi. Congratulations. Your theme, strengthening primary health care through compassion and digital innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the communities and on the front lines. I'm also excited that your theme is looking at compassion and digital innovation. These are going to be critical and will help to bridge the gap and help to improve access to children across the various communities, especially within the underserved areas. Now, on a lighter note, I know many of you family physicians are actually pediatricians at heart, and so we are happy to join you today as you deliberate on these very important issues. Thank you for the invitation, and we wish you the very best in this conference. We look forward to continuing to work with you and to partner on improving access to children across the country. Thank you. Bye-bye.
Greetings from the Emergency Medicine Society of Ghana, EMSOC. EMSOC extends its warm congratulations and fraternal solidarity to the Society of Family Physicians of Ghana, SOFPOG, on the occasion of the 12th Annual General and Scientific Meeting. We commend SOFPOG for its unwavering commitment to advancing family medicine and strengthening healthcare delivery in Ghana through continuous professional development, advocacy, research, and patient-centered care. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is both timely and visionary. As healthcare systems across the world evolve, the integration of compassion with technological advancement remains essential in ensuring equitable, accessible, and quality healthcare for all. At EMSOC, we recognize the indispensable role family physicians play as the foundation of primary healthcare and as critical partners in the continuum of emergency and acute care services in the country. Your dedication to holistic care, preventive medicine, and community health continues to positively impact countless lives across the nation. We are particularly encouraged by the focus on digital innovation, which offers tremendous opportunities to improve healthcare access, enhance communication, optimize patient outcomes, and strengthen collaboration among healthcare professionals. As colleagues united by a common goal of improving healthcare delivery in Ghana, EMSOC reaffirms its support for stronger interdisciplinary collaboration between emergency medicine and family medicine in building resilient and responsive health systems. We want to wish SOFPOG a successful and impactful 12th AGSL filled with fruitful deliberations, knowledge sharing, and renewed commitment to excellence in healthcare. Long live SOFPOG, long live EMSOC, and long live Ghana's healthcare community. Thank you. Greetings from the Emergency Medicine Society of Ghana, EMSOC. EMSOC extends its warm congratulations and fraternal solidarity to the Society of Family Physicians of Ghana, SOFPOG, on the occasion of the 12th Annual General and Scientific Meeting. We commend SOFPOG for its unwavering commitment to advancing family medicine and strengthening healthcare delivery in Ghana through continuous professional development, advocacy, research, and patient-centered care. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is both timely and visionary. As healthcare systems across the world evolve, the integration of compassion with technological advancement remains essential in ensuring equitable, accessible, and quality healthcare for all. At EMSOC, we recognize the indispensable role family physicians play as the foundation of primary healthcare and as critical partners in the continuum of emergency and acute care services in the country. Your dedication to holistic care, preventive medicine, and community health continues to positively impact countless lives across the nation. We are particularly encouraged by the focus on digital innovation, which offers tremendous opportunities to improve healthcare access, enhance communication, optimize patient outcomes, and strengthen collaboration among healthcare professionals. As colleagues united by a common goal of improving healthcare delivery in Ghana, EMSOC reaffirms its support for stronger interdisciplinary collaboration between emergency medicine and family medicine in building resilient and responsive health systems. We want to wish Southport a successful and impactful 12 AGSM filled with fruitful deliberations, knowledge sharing, and renewed commitment to excellence in healthcare. Long live Southport, long live MSOC, and long live Ghana's healthcare community. Thank you. Greetings from the Emergency Medicine Society of Ghana, MSOC. MSOC extends its warm congratulations and fraternal solidarity to the Society of Family Physicians of Ghana, SOFPO, on the occasion of the 12th Annual General and Scientific Meeting. We commend
Hello. Hello. All right, so please, break is over. Can we come inside, please? Let's come in to start the second section. Break is over, please. Break over, please. Please, let's come in. Let's come in. The break is over. Please, let's come in. Time up, please. Time up. Let's come in. We'll continue later after the second section. Time up, please. Time up, oh, time up. The time is up. Let's start the second section.
Good day, colleagues. DST members of the Society of Family Physicians of Ghana, SOFCOG. It is with immense pride and solidarity that I extend my warmest greetings to you all during your 12th annual General and Scientific Meeting in the beautiful city of Takoradi. This year's theme, strengthening primary healthcare through compassion and digital innovation, is not just timely but critical in our ongoing mission to enhance healthcare outcomes for all Ghanaians. As we gather to share knowledge and insights, let us reflect on the vital role of primary healthcare in our healthcare delivery system. It is a cornerstone of our nation's health services, and the dedication of family physicians is indispensable. Your commitment to compassionate care and the integration of digital innovation embodies the future of healthcare delivery, ensuring that our communities not only receive quality care, but also access it efficiently. In the face of the evolving challenges, the importance of collaboration among health professionals cannot be overstated. The Ghana Medical Association stands firmly with you in your endeavors to promote evidence-based practices and utilize technology to bridge healthcare gaps. Together, we can empower a healthcare workforce and uplift the lives of countless individuals.
Let's go. Time up. Let's go. Time up.
Of togetherness as we work towards a healthier Ghana, where every citizen can thrive in an environment of compassion and accessibility.
Let's go. Time up. Let's go.
All members to engage
Time up.
actively
Let's
in the
go,
discussions
please.
and workshops
Let's
over
go
the coming
in. Time
days,
up.
as your contributions are
The market
pivotal
is over.
in shaping the future of family medicine in this country. In solidarity and shared purpose, I say Ayeko, long live GMA, long live Ghana.
The
Thank
biggest
you. Good day,
now.
colleague.
Please, we'll continue later. So the section. Let's go in. Let's go in.
And the executives of
Let's
GMA
go.
Western Division.
We have a long day.
I am happy that you guys chose to have your 12th AGM in our division under the title Strengthening Primary Healthcare Through Compassion and Digital Innovation. Secondly, Takoradi, as you all know, is the Twin City. It is also the oil city, and so there's a lot to see and a lot to enjoy in the division, even as you need to discuss how to better the practice of family medicine in the country and how to even push primary health care, and then even the agenda of Ghana Medical Association as a whole. I pray that you also make some time to enjoy the sights and sound of Sekini Takoradi. You have my full support, and we the executives are ready to help you in any way, shape or form that will make your stay in Takoradi a success. Enjoy your AGM. Even though I'm not there physically with you, I send you my love, my blessings, and my other executives are there. Should you need them, they are ever ready to help you. Enjoy your stay, and we await the communique that to come out of this AGM, and we are sure that it is going to help strengthen our practice of medicine in Ghana. Enjoy your stay, and welcome to the Western Division.
Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takoradi. Congratulations. Your theme, Strengthening Primary Health Care Through Compassion and Digital Innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the communities and on the front lines. I'm also excited that your theme is looking at compassion and digital innovation. These are going to be critical and will help to bridge the gap and help to improve access to children across the various communities, especially within the underserved areas. Now, on a lighter note, I know many of you family physicians are actually pediatricians at heart, and so we are happy to join you today as you deliberate on these very important issues. Thank you for the invitation, and we wish you the very best in this conference. We look forward to continuing to work with you and to partner on improving access to children across the country. Thank you. Bye-bye. Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takoradi. Congratulations. Your theme, Strengthening Primary Health Care Through Compassion and Digital Innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the communities and on the front lines. I'm also excited that your theme is looking at compassion and digital innovation. These are going to be critical and will help to bridge the gap and help to improve access to children across the various communities, especially within the underserved areas. Now, on a lighter note, I know many of you family physicians are actually pediatricians at heart, and so we are happy to join you today as you deliberate on these very important issues. Thank you for the invitation, and we wish you the very best in this conference. We look forward to continuing to work with you and to partner on improving access to children across the country. Thank you. Bye-bye.
On behalf of the Society of Laboratory Physicians, we want to give a solidarity message to the Society of Family Physicians Ghana. On the occasion of your 12th anniversary and annual general scientific meeting, we want to appreciate all that you do for the Ghana healthcare system. We value the practice you give and how you strengthen the primary healthcare of Ghanaians. Your team is very forward-looking, and in the time of digitalization and compassion care is very timely, and we wish that you have a very impactful and successful AGSM in Takoradi. You know that the best always comes from the West. So once you're going to Takoradi for this, hello. On behalf of the Society of Laboratory Physicians, we want to give a solidarity message to the Society of Family Physicians Ghana. On the occasion of your 12th anniversary and annual general scientific meeting, we want to appreciate all that you do for the Ghana healthcare system. We value the practice you give and how you strengthen the primary healthcare of Ghanaians. Your team is very forward-looking, and in the time of digitalization and compassion care is very timely, and we wish that you have a very impactful and successful AGSM in Takoradi. You know that the best always comes from the West. So once you're going to Takoradi for this, hello. On behalf of the Society of Laboratory Physicians, we want to give a solidarity message to the Society of Family Physicians Ghana. On the occasion of your 12th anniversary and annual general scientific meeting, we want to appreciate all that you do for the Ghana healthcare system. We value the practice you give.
Hello, everyone. Welcome back from the break. We need to keep the tempo. So please, let's settle quickly. I think we have all right, thank you very much. So we'll have a brief presentation from one of our sponsors, Tridem. If the rep is here, please come forward. And thank you very much. Let's welcome her with a round of applause.
Good afternoon, ladies and gentlemen. My name is Tracy Afram. I am a medical rep and pharmacist with Tridem Pharma. So I'd like to have a brief presentation with us today. So I'll just wait for them to project the slides. Thank you. So, okay, thank you very much. So over at Tridem Pharma, we have a range of products. So first of all, we have Acupan, which is our products for moderate to severe acute pain and post-op pain. We have Florgy, which is our product, our oral dispersible tablets for the management of spasmodic pain in both adults and children. We also have Otipax, that is used for the management of ear pain. We have Bioflor, which is our probiotic that contains Saccharomyces boulardii. We also have our anti-malarial range. So we have Diatep, which is the innovator dihydroartemisinin piperaquine. And then we also have Agisan, which is responsible for changing the anti-malarial protocol in Ghana for the management of severe malaria to artesunate injection by Fosun Pharma. So with the same quality, we decided to bring some products in the cardiovascular portfolio. We have Genopa and Varosun, that are brands of Rivaroxaban and Enoxaparin. So we realized that for these conditions, that's VT, for patients that suffer from VT, most of the time, these patients are on Rivaroxaban or Enoxaparin for some time, for months, and they are not able to afford the innovator medication. So what do? We have prescribers that do not really trust generics for one reason or another because they have some experiences with efficacy. So we decided to bridge the gap between quality and affordability for the patients. Hence, Genopa, and as we might already know, pulmonary MI and stroke are the 3 leading cardiovascular diseases. Hospitalized patients, particularly after major surgeries, the risk is very high. People who even survive, 20% of them tend to die within a year, and 30% experience recurrence within 5 to 10 years. So, ladies and gentlemen, I present to you Genopa. Genopa is Tridem's brand of enoxaparin that we have in 3 strengths. We have 40 milligram, we have 60 milligram, and we have 80 milligram. Genopa is manufactured in an a US FDA approved manufacturing plant. Hence, we are guaranteeing the quality, we are guaranteeing the safety, and we are guaranteeing effectiveness. Also, as family physicians, we are also guaranteeing cost effectiveness without compromising quality, because Genopa is manufactured in a US FDA approved manufacturing plant. Genopa is also bioequivalent to the innovator medication as well. Also, for the management with the use of Rivaroxaban, we have Varosun. So Varosone is Tridem's brand of rivaroxaban that we have in 3 strengths as well. We have 10 milligram, we have 15, and then we have 20 milligram. So for Varosone, we also have a bioequivalent study on the strengths of Varosone that shows that Varosone is actually bioequivalent or biosimilar to the innovator medication. So you know, if your patients cannot afford the innovator and you want to give a brand of rivaroxaban, we can always vouch that when you give Varosone to your patients, you are going to get a similar efficacy profile and a similar safety profile. So you are not compromising quality, but then you are helping your patients in terms of cost as well. So for both the 10 and the 20 milligram, we have the bioequivalent study that shows that Ginopa has a similar efficacy profile and a similar safety profile as well. So at this point, I've introduced 2 products in the management of VTE. So we have Ginopa and then we have Varosone, our brand of enoxaparin and our brand of rivaroxaban. At Tridem Pharma, we bring you quality with our range of medications from Acupan, Bioflow, OT-Packs, our adjuvants and our diatabs. We are bridging the gap between quality and cost with our cardiovascular medications. That's the Varosone and the Ginopa, our rivaroxaban and our enoxaparin. Thank you.
Thank you very much. Our representative will be around. If there are any questions, you may please see her for that. Okay, thank you very much. Let's appreciate Tridem once again. So we move on to our 4th oral presentation on antimicrobial resistance patterns at a single-site orthopedic center in Accra, Ghana. And the presenter, someone I've known for so many years, is Dr. Francis Adai. He's a family physician specialist and a diabetologist, and is currently the consultant and head of medical service at Focus Orthopedic Center. Let's welcome Dr. Adai.
Good afternoon, our most respected Reverend Professor Chair. Good afternoon, the Vice Rector of the Ghana College of Physicians and Surgeons. Good afternoon to the able neck of Suffolk for the opportunity given to Focus to do this presentation. And good afternoon, colleagues. It's my single honor to present on behalf of the Focus team. Even though the research is my idea, it's a team, and I want to say that most part of the work was done by the research team of Focus. So I'm just a servant. So this will be the outline of my presentation. We all know the global threats that antimicrobial resistance poses. The biggest challenge has been that despite the awareness, every 18th November of the year happens to be a day dedicated for antimicrobial resistance awareness. Despite the ongoing awareness, our attitudes, especially as clinicians, unfortunately has contributed so much to the burden of antimicrobial resistance. And as head of the Pharmacy and Therapeutic Committee of Focus, I realized that we're having a big challenge when it comes to the choice of antimicrobial agents, especially among our surgeons who were coming from outside. Some were doing their own thing. So we had to make a case and influence policy, influence our antimicrobial choices as an institution. And that is the basis of our work. So the key things we sought to do was, one, among our cultures, what were the common bacteria agents. Specifically, I'm using the word antimicrobial broadly, but specifically, I'm talking about bacteria agents and therefore antibiotics. Okay, so I may use antimicrobial and antibiotics interchangeably. So we sought to look at what are the common isolates from the samples we took over a 5-year period. It was a prospective study. So we looked at samples from blood, samples from surgical site infections, both superficial and deep surgical site infections, including tissue cultures. We looked at our samples from urine. And the question was, what are isolates, the common isolates or the dominant ones? And then also we sought to find out which antimicrobial agents will work against these isolates. Because most of the work we have national, we have international, but as an institution, as an orthopedic center, what have we found and what is going to influence our antimicrobial choices in the area of prophylaxis and then empiric treatment? So that was the basis for this study. The methods, as I've mentioned, it was a prospective study, 5-year, and then we had thousands of data that we had to look at, but we had to screen them and then just work with the bacteria isolates. Okay, so we actually work with 916 isolates within the study period. So I'm going to move to the results and then we'll have some brief discussions. So these were the results. The bulk of our isolates from the samples we took were gram negatives. And this is in sync with some national data. Okay. The bulk of our isolates were from gram negatives, mainly E. coli and then Klebsiella. Of course, we had some gram positives as well. If you look at this table, there is some striking thing I need you to pay attention to. The area in the red are those who were resistant, okay? The area you find in the green are those who are susceptible. The preferred term is not sensitive anymore, it's susceptibility. So that is the green. And then where you find the yellow are the intermediates. And these were based on MICs, the minimally inhibitory concentration areas. Okay, those usually beyond 80%, 80 and above will fall under the greens in that order. If you look at, I want to dwell on the cephalosporins. If you look at E. coli and then Klebsiella, you realize that even among our third generations, we found very, very high resistance strains. And when I joined the center, our surgeons were using ceftriaxone a lot as one of their prophylaxis and then intra-op prophylactic agents. Following this data, within just 2 years, we hadn't finished, but we were able to, through the PTC, influence our choice of prophylaxis at focus. And as we speak now, we hardly even use the cephalosporins. The resistance we saw was so much with the cephalosporins among the two agents, and that has influenced our antibiogram currently. The other striking thing with these two agents that we found were quinolones. If you look at Cipro, the resistance was so high among these two strains. Okay, so when it came to our empiric choice, when we talk about urinary tract infections, of which was the second most common sample that we dealt with, we moved away from the quinolones. And at focus for our uncomplicated, we use more of fosfomycin nitrofurantoin. For our complicated, if there's no renal impairment, we go more for the aminoglycosides in the case of amikacin. we also analyze the gram positives. Among the gram positives, we have some MRSA results, but what is striking among the gram positives were the coagulase negative organisms, like Staph epididymis, Staph saprophyticus, hemolyticus. These are normal commensals, but strangely, we found some, because we are an auto center, we found some in our deep surgical site infections, and then even some tissue cultures. So then the question is, which antibiotics were we going to use against? Unfortunately for us, these normal commensals that we isolated, again, were very resistant to penicillins. And if you realize, the WHO reserved antibiotics were the ones that were working against these normal commensals that we know, vancomycin and then linezolid. And that poses a big challenge for us as an orthopedic center. So this is the last table of my results. For those that were resistant, we further stratified or classified them into multi-drug resistance. We also extensively drug resistance, and lastly, pan-drug resistance. I think during question time, I may have the opportunity to explain this. Even though we didn't find a lot of them being pan-resistance, we had quite a number of them being multi-drug resistant, just as has been seen at the national level and in some institutions like MDS Lancet, the work of Dr. Samoa and co. And I think these are very important findings for us as an institution. So the key discussion here is that for us as an orthopedic center, we realized that multi-drug resistance was an issue. And therefore, quickly we had to influence policy. And as I speak to you now, we've changed our choice of prophylactic antibiotics. We've also changed some agents we were using before for empiric treatment, and that has gone a long way to help us. So in conclusion, the burden of antimicrobial resistance is huge. And over the years, we've not had a lot of institutional data and surveillance. And it's something we want to preach to the rest of us, that wherever you find yourself, your decision to use an agent should be informed by data. The arbitrary choice of antibiotics or antimicrobial agents is not helping. It's rather making the case worse. So this will be our message to colleagues this afternoon, that we need to choose and choose well from our antimicrobial agents. Thank you.
Thank you very much, Dr. Adai. That was an interesting. So our next presenter is also a family physician specialist, head of infectious disease at University Health Services at KN University. Nana Abrukwa, right. She's going to present on advancing rural health coverage through digital health. Okay, so Nanekia, right. Great. So after Nanekia, we're going to skip the discussion, and then we'll have a presentation. Then we'll have the last two questions. Then we'll have one discussion. Thank you.
Thank you very much, Prof. Good afternoon, everyone. I hope you're all doing well. As Prof introduced me, I'm Nanekia Abrokwa, and my presentation today is From Q to Click, Transforming Student Healthcare Through Digital Innovation. I know a lot of us went to secondary school and the universities, and whenever we had to do medical screening, it was long queues. We had to sit down and have our information written down before we had to see the doctor. And after that, we had to wait for our results. There were a lot of things that were going on. Some of us didn't even do our medical screening as a result, but we are still doctors here today. So I asked AI to give me a picture of myself, and I came up with this. Usually we've heard of the maxim, jack of all trades, master of none. A lot of us as family physicians have been put in that category, that most of the time we are a jack of all trades, but we never specialize in anything in particular. Now, when it comes to digital innovation and digital tools, we see that they are also taking over gradually. So sometimes we rely on ChatGPT, we rely on Google to be able to give us information about certain things. And we sit in the consulting room and we think about the long patient queues that we have. So this is me trying to balance patient education, patient healthcare, public health, looking at the appointment list that I tend to have most of the time, and looking at how all these systems can work together in a seamless manner. So are we trying to build a platform that can book appointments, reduce queues, save time, improve healthcare access, satisfy students in our hospital, and maybe help them to even make sobolo along the way? This is what we hope to accomplish. So this is my outline of my presentation for today. So we all understand that achieving universal health coverage is a major aspect of SDG 3, and we would love to be able to have equitable access to healthcare without undue financial burden, but sometimes it's just not probable. Now, next slide, please, sorry. Okay. Oh, sorry, I can change from here. Right. So when it comes to our setting, we see that students are highly exposed to technology. We call them the Gen Zs. They are very tech savvy, but at the same time, they also tend to utilize healthcare services. In actual fact, we have about 155 students visiting our very small clinic every single day. So we understand that there's a huge pressure to be able to take care of these students every single time. Now, the digital information that we provide them can also influence their health-seeking behavior. So the university management set up what we call the Students Online Health Appointment System to be able to streamline students having to book for appointments to be able to see a general practitioner at our hospital. So before we get to the crux of the matter, we have what we call implementation outcomes. So when we implement an activity, we want to see whether that activity is acceptable to the patient, it is appropriate for the patient, and it is feasible. So we wanted to find out whether the SOHAS, as we call it at our facility, was acceptable to the patients, was appropriate, or was also feasible. Now, we use certain frameworks to be able to do this. We have what we call the acceptability of intervention measure framework. We have the intervention appropriateness measure framework, and then we have the feasibility intervention measure framework. Now, this was developed by Wiener et al., and it helps us, these frameworks help us to be able to understand whether what we implemented was actually acceptable to them, whether it was feasible, and whether it was appropriate for the student population we were looking at. Now, the research that has been done in the past, a lot has been focused on uptake. So we want to know whether patients are willing to take up something, whether it is a new app, whether it's a new platform, whatever it is. But we've never been able to see some hidden attitudinal profiles that they may have. So they may appear in one form, but then there are other things that we need to be able to evaluate. And that is what we did with this study. So if it is acceptable, appropriate, and feasible, then we understand that they are likely to adopt it and they are likely to use it going forward. So what did we do? We conducted a cross-sectional study. We conducted a cross-sectional study in KNUST, the university hospital. So the hospital actually has a standalone clinic that attends to over 80,000 students. and that is the current student population. I mentioned that there are about 155 students that attend the clinic every single day, give or take. So it's a very, very heavy clinic. And the study period was from the 20th August to the 30th of September. And eligibility was all students who had completed their biometric registration for the semester were eligible. And any students who had deferred their course for the semester was not allowed to participate in this study. Okay, so this is the study overview. Using standard formulas, we were able to tabulate and see that we're going to get about 422 patients who were eligible to partake in the study. Now, we surveyed them via an online platform that also was able to reduce duplicates. We increased the number to 500, and then ultimately there were 511 students who responded to us. So the online invitations were sent, and there was a secure link that was given to them to be able to participate in this for us. Now, we took their demographics, we took information about their healthcare use, and remember these three, their attitudinal profiles, so we could classify them. Then we had latent class analysis, and we did a structural equational modeling for them. These are big words. I will hope to break them down a little bit more. So a latent class analysis is, for example, if you have patients at a clinic, they all are hypertensives, and they've come to see you. Usually you will take blood pressure, the pulse, the respiratory rates. You ask them about whether they've taken their medications or not, but you would want to find out more about them. Why are they not taking their medications? Why do some of them skip visits? Why is it that some people are always coming? Why is it that some people tend to stay longer than they should when they come to see you at your hypertension clinic? So these are hidden profiles behind what we will see just as a number of 150/90. So when we see 150/90, we say, oh, you are not controlled. If we see 120/70, oh, you are controlled, take your medication. But a latent class analysis helps us to go deeper into the information that we are getting and tell us, well, this patient is probably having challenges with A, B, C, D, E, and this is how we can support them. So for this particular study, we were able to classify them into 4 attitudinal profiles. There were people who we called the enthusiastic supporters. So we'll go further into it in the next slide. Yes. So I mentioned that there were about 511 students who participated in the study. We had more males than females participating. There were about 71% who had already attended the university to seek healthcare before, so that was very encouraging for us. 69%, about 69.7% lived off campus, and over 90% of them wanted to receive text messages as their form of coming on to get health care from the hospital. Now, they indicated that poor internet connectivity was the most common challenge for them when it came to seeking healthcare. Now, I mentioned the 4 attitudinal profiles. We had the enthusiastic supporters. So these were very, very excited about using the online health appointment system. We also had the ambivalent users. They were moderately positive about it. There were conditional supporters. They wanted several things to change so that they'll be able to use the service more. And then we had the skeptical or resistant users. They just didn't want to engage with the technology. So what influenced their attitudes? We saw that there was no significant differences in their baseline attitudes, but previous access to the hospital also did not differ across those groups. Most students saw that they preferred to use text messages, and they perceived that the challenge about internet connectivity was all the way throughout them. Thank you. All right, sorry. So I would want to go quickly. So the key takeaway points is that most students view SOHAS very, very positively, and it's something that especially the enthusiastic supporters supported. So from the latent class, we noticed that we need to be able to engage all students, but be able to see different students at different levels to be able to help them better, reduce ambivalence, and then gender inclusivity is very important. We saw that there were more males than females who responded to this particular study. Now, my recommendations are here. I'm just going to go through them. First of all, we have to strengthen infrastructure, and I think we spoke about it during our presentation this morning. Gender responsive strategies are very important. Tailored engagement to be able to know what each class needs so that we can support them, and then expand some adoption frameworks. So I come back to this slide again. We always say that we are jack of all trades, but we are masters of none. In actual fact, I saw the full quote of this presentation, and it says, jack of all trades, master of none, though oftentimes better than a master of one. So in actual fact, we are actual masters of a lot more than we actually think. And I think digital innovation is going to be very, very important going into the future when it comes to students' healthcare access. Thank you. These are my references and a very special acknowledgement to all these. Thank you. So we had a paper published on psychometric acceptance of this particular presentation that I did. You can scan the QR code if you want further information about what was done in the study. Thank you.
Thank you very much. Wonderful work being done at KNUST. Maybe you have to come and consult you. All right. Thank you. So we'll now have a presentation by EXFA. If they're not, okay. Oh, all right. Okay. Okay, so I'll have to President to do that. Good.
Thank you very much, Prof. and Chairman, for this occasion, and thank you so far for the program. So at this, we've reached a very important aspect of our scientific session where I would like to invite a corporate body that has truly supported us throughout this whole partnership, AGSM program. And I was actually hoping to see the General Secretary of Goldfields Ghana Foundation, Mr. Razak, to be here, but unfortunately he couldn't make it. But he has sent his project manager, Madam Aisha Muhammad, who will ably present him to make a short presentation and give a fraternal message to us for their support. And as she walks out, let's give her a hand. As she walks out, I'll tell you a little bit of what they did to support us. So when we approached them through our treasurer, they didn't hesitate at all, and they collaborated very well with us. For about a week, we met them and they helped us do surgical outreach for the people of Takwa. And we screened almost 200 people. We had surgeries for almost like 100, 3 of them. Most of them had inguinal hernias. And all the cost, everything that went into this for them. As if that was not enough, on Saturday, we had a medical outreach where we collaborated with them, and they showed up. And you know, sometimes you do medical outreach and the medications you are giving are generic medications. These are branded medications. I had to actually pick up Nexium. There was nothing that we needed that it wasn't there. They hosted us very well. So if I stand here, I'll bore you. So please, madam. Please.
Okay. Thank you very much. As our president said, it's unfortunate we didn't have our executive secretary, Mr. Abdul Razak Yakubu. In fact, he's being caught in a tight meeting that he couldn't join us. So as we were at the backstage, people were asking, what is Goldfields Ghana Foundation, or what is Goldfields? Please, we are not a pharmaceutical company, or we are not doctors. So we have, let me give a brief background. So we have Goldfields Ghana Limited, and we have Goldfields Ghana Foundation. So the Goldfields Ghana Limited is the mine itself. We are into mining, and the Goldfields Ghana Foundation is, we do the CSR project. So we are community developers. So please move forward for me. So my presentation is basically going to be focused on health intervention. So this is a brief background of Goldfields Ghana Foundation, funding, governance, strategic pillars, and strategic pillars in health as well. Please move to the next slide. So this is our history, our journey. It started in 1993, then we registered the foundation in 2024. So we, as I said, we have our 5-year strategic development plan, legacy programs, and also to increase our visibility. I think most of us here, this is the first time of hearing our Goldfields. So we have few brochures that you can pick and get to know more about us. Please, the next slide. So this is how we get our funds to support such programs, events, and other interventions in our community. Any 1 ounce of gold goes into the foundation's account, 1.5 pre-tax or before tax. Then you have the scraps, sale of scraps like the metal scraps to also goes into our fund or our account. Then 90% goes to community development or GLP. The GLP is group legacy programs, something that Goldfields Ghana Foundation will do. And when it gets to TAQWA, when we talk about good health care, you mention TAQWA, you're not mentioning anything else. So we have 21 host communities. That was then when we had the Daman Gold Mine and the TAQWA Gold Mine. We've successfully transitioned to engineers and planners. So we have TAQWA Gold Mine currently. The next slide. So we have, this is our governance. So we have managing trustees that every quarter we meet them to give account of what we've done. So we have the member of parliament. We sit in two municipalities, Christian Huni Valley and TAQWA in Suayem. So, and that's our organogram. So the executive secretary, project manager, the safety and other officers of the foundation. So these are major pillars, our interventions. We have education. So we do scholarships. I don't know whether you have one of our beneficiaries here. So our scholarship cuts across all public universities, whether you are doing medicine or any program that is acceptable. We also do health. This will be our main focus. We have water and sanitation, we have agriculture, and we have infrastructure. People bring request for sponsorship. We don't look for, we don't sponsor overseas travel, religious groups, and other political party sponsorship. We don't do that. So please, if we are in a political party or you want sponsorship for us to travel overseas, please, we don't do that as well. So this is our total investment to date. We invested 109.92 million in community development. Yes. Then the health sector too is also set at 5.5 million upwards. Yes. So we are going to focus on our health interventions. So for health, either the soft programs or the physical infrastructure, our focus is to improve primary health care delivery, enhance overall health care and well-being of our communities. And also, we have focus areas like preventive health care. So when we did the medical outreach on Saturday, I was on the doctors that we are focused on hypertension, so the education should go well. The medications are just an add-ons to it. So when people are able to understand or get to know that when I do this, the lifestyle change their life, it is going to reduce the cases of hypertension and other preventable diseases. So ours is preventive health care in terms of our soft programs that we do. Please, let's go to the next slide. So as I said, these are some of the things that we do. We have the World Health Days, and we have one major partnership with Project Cure. They're in America, so they have the Cure Cargo program, which they provide us with essential medical equipment and consumables to stock up our health facilities. Last year, we were able to get 3 containers, and hopefully this year, we are getting 5 containers full of consumables and equipment to stock up our facilities to improve healthcare delivery services. The next slide. So like this, one of our outreaches that we do. We also add health insurance to it. So free screening and consultation. And we use our doctors, those in our medical field, those who have gained scholarship from us before. Some are working elsewhere. So during medical outreach, they also give back to their community. So most of them that you see are our medical, like our scholarship beneficiaries who have graduated and working elsewhere. We use them to do the medical outreach as well. We add health insurance free registration to the outreach programs that we do. So these are overview or gallery of some of the health outreach that we do organize. Oral screening, preventive health education. Yeah. Next slide. So this is a summary of what we've been doing. We also do this in partnership with the Municipal Health Directorate. Yes. The next one. Okay, so these are some of the interventions that we do. So this is just a summary and a gallery of our interventions in terms of the programs in the health space. The next one. Okay. I'm not going to talk much, so just view and see. And I think SoftPOC will be one of our main partners as well going forward. So so this one of the major partners I highlighted with Project Cure, their cargo program. And during the presentations, I saw that maternal health care is also at a decline. So we are going to also channel our efforts in improving maternal health care services. They also have other programs that they do, which is also into maternal health care. So after this cargo program, we have to have taken some contacts here that we will try and discuss and see how best we can improve our maternal health care services in the municipalities. So these are some of the items that we receive. It's good to note that we there's a facility in Pista Huni Valley. They had this small room that they needed to improve on it and use for, I think, for their incubator. So fortunately, the items came in, they had one, and they are successfully using it and also doing some surgeries and other things that they didn't use to do it. They have to travel from Aboso or Subri or Daman to municipal hospital to get some of these services. So with this intervention, the opening space for the maternity ward and all that, they're able to expand their services. So we have the adolescent health programs in all the public basic schools that we operate. These are adolescents. We have the peer educator training. We train the peers to also train their fellow students in adolescent healthy lifestyles. So please, the next slide. So these are the peer educators. Every quarter we engage them, give them training, then they also take it to their various schools to train their various peers with the help of Ghana Health Services and Ghana Education Services. Yeah. So we move to the infrastructure projects. We have 7 clinics. In fact, I don't want to mention all. Let's go to the gallery so that we see the pictures. So this Aboso maternity block. We have the Huni Valley Clinic, and we have Huni, so the facilities, Bompia, so Daman. So that's Aboso maternity block. So before and after pictures. So the before is the one up there, and the after pictures is the one below. Yeah. So we also donated some ambulance to Municipal Hospital, UMAT Clinic, and Apinto. You know Ghana, so we have to preach about sustainability. We donate, we provide, and we have to take care of it so it becomes sustainable. Not that we donate and supply, then we come back again to renovate. So these are some of the interventions. So we have this doctors and nurses accommodation. In fact, I said this design, I have to contact the contractor to build same for me. It's well furnished and very conducive. So the doctors at Huni Valley, and the nurses and Huni Valley, they have this accommodation. Isn't this beautiful? Yes. So what we've planned ahead, very soon we are going to make noise at the various social media platforms. We are constructing an accident and emergency center for Apinto government, in fact, the modern type of hospital. We are going to fully renovate, please go back. We are going to fully renovate the OPD department and stock everything that they will be needing. So very soon, when you go there, when you go to Apinto and you go to the emergency center, I went there and I was like, when you have an emergency, see how the place look like. So Goldfields came in and we are going to intervene massively, going to stock up everything that they will need, and in fact, give it to the best of capability we can. So these are some of the things that we are also doing in the health space. The next slide. This is just a summary of all what we do. The medical outreach, the World Health Days, the cargo program with Project Cure, the infrastructure projects that we do, all contributing to SDG 3, 17, and 4 and 9. Yes, so on behalf of Goldfields Ghana Foundation, we want to say thank you very much for giving us this opportunity to be part of your 12th annual General Scientific Meeting. Thank you very much.
Don't go. We have a presentation. So please don't go. We have a short presentation for them. They are not aware. I'm sure they are surprised. So I'll quickly read the citation we have made in their honor, and I will ask Dr. Ayer to please step out. He is our board chairman and the first president of the Society of Family Physicians of Ghana, so that we help present this to them to show our appreciation. So it reads, citation in honor of Goldfields Ghana Foundation. The Society of Family Physicians of Ghana, SOFPOC, proudly honors the Goldfields Ghana Foundation for your exceptional commitment to advancing healthcare, improving community well-being, and supporting sustainability development in Ghana. In recognition of your long-standing investment in health promotion, healthcare delivery, and community-based interventions, particularly in mining communities, SOFPOC deeply appreciates your valued collaboration in 2026 through the successful partnership in delivering a medical and surgical outreach program in Takwa, bringing quality healthcare services to underserved populations. We further acknowledge your continued support for SOFPOC's activity, which she has attested to. So going forward, we have a partnership with them and shared commitment to strengthening primary healthcare and accessibility for all you. Thank you so much. So thank you so much. Sorry, apologies for the time, but we hope to speed things up. I hand it over to the chair where we have Denk Pharma presenting, and then we continue. Thank you.
Okay, thank you very much. Another round of applause to Goldfields. It's a very interesting world. Okay. All right. So it will interest Goldfields to know that so they built the health center in my village Bompiaso. So extend my greetings to Mr. Razak. I was hoping to see him here. Okay, thank you very much. We'll have some more time to talk. So you are the right place. So we want to invite Denk, okay, to present to us. Shall we welcome him? Please come. Yes.
Thank you. Good afternoon, everyone. My name is Sandrine Kumpole, and I work with Denk Pharma. I'm a medical rep. I'll be taking you through a very short presentation on one of our newest products. And we have our topic here, Beyond the Molecule, Enhancing Therapeutic Outcomes Through Innovative Dosage Forms. So our objectives for today, 1, to explore why this conversation matters. 2, to analyze the formulation problem when it comes to healthcare, and then we'll look at the solution Denk Pharma offers you, and then we conclude. When it comes to pharmaceutical care, dosage forms play a very critical role because they determine the safety, bioavailability, and the efficacy of a medication. And the method by which a medication is delivered directly impacts whether the patient is going to adhere to that treatment regime or not, and then ultimately therapeutic outcomes. So when you have a dosage form that's not doing the work it's supposed to do, it can lead to treatment failure and then also antimicrobial resistance, which we are all trying to avoid. Now, there are some problems when it comes to formulation in healthcare. For instance, if you have tablets, sometimes it's difficult for the patients to swallow. If you are looking at elderly patients, those who have gone through certain surgery procedures, they find it difficult to swallow these big tablets, and it goes a long way to affect their well-being. And for these tablets, sometimes the nurses have to crush them for the patient so that they can take them. And this can lead to the loss of the dose, taste aversion, and then also lead to affect the efficacy of the product and then the patient's safety in the long run. Also for suspension, sometimes you need very high volumes, and this goes a long way to increase the cost for the patient. And we cannot also be guaranteed of the stability after it has been reconstituted. These days, our temperatures are so high, sometimes you put things down and within a short while, they are getting, rotten. So we need to look at all these problems. There's also the issue of underdosing or overdosing. We have different types of spoons on the market, and the patients sometimes get confused as to which one exactly they need to use for their medications. So these are real, world problems people are dealing with. The patients are dealing with. Pharma offers you a solution. I would like to borrow a saying from Michael Dell, the CEO of Dell Technologies, which says that innovation is not about ideas, it's about solving real problems. So you don't just innovate for innovation's sake, but there needs to be a problem that you are attempting to solve. And this is the solution Denk Pharma offers you. Amoxiclav Denk 1,125 milligrams dispersible powder. Amoxiclav Denk 1,125 milligrams dispersible powder. So for your patients with respiratory tract, eyes, skin and soft tissue, dental, ENT infections, even H. pylori treatment, this medication will be a very good fit for them. So Amoxiclav Denk 1,125 milligrams sachet comes in powder form. It comes in a box of 12 sachets. And the amoxicillin content in it is a full 1,000 milligrams. It's not 875 milligrams like what we have on the market. It's 1,000 milligrams. So you just put it in a bit of water, about 50 mils, you mix, and then the patient drinks, and you are good to go. Yeah. There are some challenges when it comes to the high-dose amoxiclav tablets. And these include swallowing difficulty, like I mentioned earlier, in adults and elderly patients and pediatric patients. And research shows that 35% of adults who are age 65 and above have difficulty swallowing tablets. And this low adherence and in the end antimicrobial resistance because they fail to complete the course. Research also shows that adherence to oral antibiotics decreases significantly with pill burden, bad taste. So if you have a tablet that's already too big, the patient finds it difficult, adhering to the treatment regime. And there's also limited flexibility. It's not suitable for patients who are on feeding tubes, the NG tubes. And so when you have the tablets, the nurses have to crush them for the patients to take. But with amoxiclav dispersible powder, you just mix with water and then you give to the patient. You are good to go. Yes. There's also intolerability when it comes to GI. You have patients experiencing nausea with these tablets, and that's number one reason for early discontinuation of their medication. They take it and they feel uncomfortable, they feel the nausea, and they decide they can't take it anymore and stop midway. Now this is a graph comparing dispersible amoxiclav with the conventional tablets. And you can see from the curve that amoxiclav dispersible reaches peak concentration significantly faster, about 30 to 45 minutes before the conventional tablets. So that means your patient who takes the amoxiclav dispersible powder is on his or her way to getting better than the one who has to take the tablet because they have to break down before it is absorbed. So now let's look at a real world scenario. Meet Yao. Yao is a patient who almost gave up. He had surgery for tonsillitis. He's 58 years old, and he was prescribed amoxiclav tablets, amoxicillin clavulanate, 1,001 to 5 milligrams conventional tablets. He started taking it, but then he realized it was too difficult. And by day 3, he stopped taking the tablets. So he went to his doctor and said, "Doctor, I'm struggling. I can't continue with this. Please help me." So the solution, the doctor prescribed amoxiclav dispersible powder for him. He just mixed in about 50 ml of water. He drank it, very easy to administer. And by day 6, he was good to go. He returned to work in a happy mood. So why should you prescribe our amoxiclav 1,001 to 5 milligrams sachet? Research shows that Research shows that there's comparable efficacy of the 6-day treatment. It comes in a pack of 12 sachets, so that's a 6-day treatment. And it shows that the 6-day treatment course is as effective as the 7-day treatment course because of the 1,000 milligrams of amoxicillin you have in there. And you are also assured of product stability because the patient mixes it as and when he needs it. You don't mix and put down. And this improves patient compliance, and there's minimized resistance risk. It's also beneficial for vulnerable patients like the elderly pediatric patients over 40 kilograms and those who find it difficult swallowing these huge tablets in general. And there's also a reduced risk of drug-induced esophagitis. Research shows that amoxicillin is a culprit when it comes to that because it gets stuck in their throat and they feel uncomfortable. Yes. And after all this, you are assured of the Denk Pharma quality. All our products are manufactured, quality controlled, and registered in Germany. And we also have proven bioequivalence where we compare with the innovator company. So over here, we compared amoxiclav Denk 1,001 to 5 milligrams with augmentin 1,001 to 5 milligrams. And we realized that the products are bioequivalent in terms of rate, extent of absorption, elimination, and they are both very well tolerated. Like for all medications, there are certain precautions you need to take into account when you are giving them. If you have a patient with renal impairment, you do a dose adjustment when the GFR is less or equal to 30. hepatic impairment, you can give, but you monitor the hepatic function at regular intervals. For pregnancy and breastfeeding, when the potential benefits outweigh the potential risks. Side effects are mainly GI effects, nausea, diarrhea, vomiting. So in conclusion, we say that formulation matters, just as your choice of antibiotic. And swallowing difficulty is a real problem when it comes to pharmaceutical care. And inconsistent dosing drives treatment failure, recurrence, and ultimately antibacterial resistance. And therefore, we give you amoxiclav dengue dispersible powder, which removes these barriers by ensuring that your patient has a reliable dose exposure, there is easy administration, better adherence, and therefore better clinical outcomes. And so we say the molecule works. So far you've been prescribing it's working, but the formulation makes it work better. I'll just introduce, this is also one of our newest products, pregabalin dengue, 75 and 150 milligrams. And then we also have pantoprazole, Pantodengue, 20 and 40 milligrams for your patients. If you need a PPI with the lowest drug-drug interactions, this is your best bet. And then we have immune active to boost the immune system of your patients. It's been on the market for about a year and it's doing a very good job. So we would like to have you on board. Thank you very much. And we have a PV department, so if there's any issue with our products, kindly contact us. Yeah, thank you.
Thank you very much. I believe she'll be available to interact with anyone who has some inquiries to make. Once again, a round of applause for Dengue Palmer. So our next speaker is Dr. Obed Sapon Dusay. Obed is a family physician specialist working at the SDA Hospital, Asaman in Kumasi. He's going to present on validation of the patient-doctor relationship questionnaire. Quite interesting. A cross-sectional study among exit patients in Ghana. You're welcome, Dr. Obed.
Good afternoon. So, this study came about 2023 when I joined the AfriOne research group. We were supposed to undertake a study as we take mentorship lessons. And what we decided on doing was to assess patient-doctor relationship. And we had to validate these two in Ghana. So I was the lead investigator, then author as well. We have in the team Dr. Spangenberg, the former HOD and founder of Family Medicine Training. We also have two Nigerians, Dr. Ghana and then Dr. Ozzy. Then we have Dr. Sergi Kalala from Democratic Republic of Congo. So when I see patients, what I use to assess whether I did well in the consultation are two things. Whether they ask to see me again or they ask of my contact. If I don't get any of these, it means that the consultation didn't go well. That is my assessment, my subjective assessment. I don't know about how you assess yours. And the fact that mine is subjective, it means that yours can also be subjective. And in measuring outcomes that are abstract, you have to ensure that you consider people that you are assessing. Contextual input comes in. And you have to do a psychometric analysis to understand whether the tool you are using for the assessment is actually valid among the population that you are studying. So that is the background for our study, and the objective was to validate the PDRQ. So this is how we did it. So initially we adopted a tool from the Netherlands, which was designed in 2004 by Van der Vers, Cornelius, and colleagues. And so because we are going to use it in Ghana, we have to validate it. So we asked some family physicians of high experience, about 5 years, 3 of them, to assess whether the questions that are in the questionnaire are able to assess consultation in primary care. We did the qualitative form of assessment and it passed. Then we gave to 10 patients who were also going to answer these questions in a different site. And then they didn't have any complaint about reading or assessing or understanding the questions. So it also passed. So it means that our face validity and content validity was okay. So we sent the tool to the field. At the field, we did the cross-sectional study at the Confanochi Teaching Hospital, Family Medicine Outpatient Department. That was in October 2023. And we used systematic sampling for selecting our participants or respondents. We used 366 patients. In validating a tool, you need more than between 200 and 300 participants. And the ratio for validating a particular tool, you need one person for each question on the questionnaire. You need 3 participants or 20. We chose 20, but it was 180. It means that we had to increase to get the validation done. So that's why we increased to 366. In terms of conducting construct validity, we did a proximal component analysis, and we used the Kaiser criteria, which says that if you have an eigenvalue greater than 1, it means that that factor is something that you are measuring. Any factor that is less than 1 is dropped. Then we use script plot to confirm our analysis to see whether the single factor that we got was confirmed. And that one to confirm that it was a single factor, which means that the tool is unidimensional. It can only assess only one factor, which is the patient satisfaction. And then the factor loadings were greater than 0.4, all of them. It means that all the indicators or items on the tool were answering the same construct that we are assessing, which is patient satisfaction. We also did a reliability analysis to ensure that the tool is actually valid in Ghana in combination with the construct validity. And the Cronbach alpha was calculated, which is something that we used in validating unidimensional tools. So this is how we went up. So in the results, you see the factors. We had 9 factors. Only the first factor had an eigenvalue, which is 7.29, above the 1 threshold. So it means that there are latent factors there, which is assessing something, or it may be supporting the patient satisfaction, but they are not that strong to stand on. So we dropped all those and focused on the factor, which is 7.29. And when we did the script plots analysis, which is confirmatory factor, it also showed that only 1 factor was present. And we are able to determine that using the bend of the curve. So if you see the slope where it bends is on the 2nd factor, and that means that from that onwards, they are not responsible for whatever we are measuring. And the single factor we were able to get was able to explain 81% that we are assessing, which made it very valid. In terms of the factor loading, which is saying that all the indicators, the questions that we will be asking, they are all geared towards patient factor, all of them were above 0.4, which means that they are working together. And the likelihood ratio also shows that it is significant, meaning that you can't separate each of the questions from each other. Internal consistency reliability, the Cronbach average was 0.58, and the original two that was developed, they had 0.94, which is something very similar. So in conclusion, we say that the PDRQ Ghana version is validated, reliable, it is unidimensional, and can be used in assessing doctor-patient relationship objectively, which can be comparable at different sites when the same tool is used. And it is something that can help in patient management and quality improvement assessment of consultations in Ghana. Thank you.
Okay, thank you very much, Dr. Obed Sapong Eduse. Another round of applause for him. I was looking out for the items of the PDRQ, but I think you brought them up later on. Okay, so our final presentation, oral presentation, will be done by Dr. Abena Edufo, also a family physician at Princess Mary Louis Hospital, I believe in Accra. And she's going to present on clinical breast examination findings and associated factors, women screened in Ghana, a multi-center cross-sectional study. You're welcome.
Thank you very much. Okay, so we know that October is breast month, and every October we carry out breast screening, but we don't really look at the data and analyze it to see any trends. This time around, last year, we took some data from SOFPOG, did a breast screening program at the four teaching hospitals, and we collected data. So this is just an analysis of the data that was collected during the breast screening program. So the title is Clinical Breast Examination Findings and Associated Factors Among Women Screened in Ghana, a multi-center cross-sectional study. Sorry, the authors to the paper are displayed below. Okay, so breast cancer remains the leading cause of cancer death among women in Ghana, and not even just in Ghana, in the whole world, but it's a problem in Ghana, and most of them are diagnosed very late, at a late stage. So clinical breast exam is an early screening tool to be able to detect any breast abnormalities in women, and it's very helpful in low resource settings. However, data from breast screening programs on the prevalence of breast abnormalities through screening and associated factors to the finding of breast abnormalities are limited. So we set out to find out these factors and find the prevalence. Okay, so our objectives were just two. First, we wanted to assess the prevalence of breast abnormalities picked up by breast screening, that's clinical breast exam. And the second was to determine factors associated with breast abnormalities among women. So the methods, it was a multi-center cross-sectional study. The population were women attending screening at the family medicine unit at Komfanochi Teaching Hospital, Kolebu Teaching Hospital, Cape Coast Teaching Hospital, Tamale Teaching Hospital. So the period was October, the month of October, so it was 1st to 31st, and breast screening was carried out every weekday for the month. So a pre-tested questionnaire was used to gather data from participants. And we screened everyone by clinical breast exam. And then those who had abnormalities detected were referred for mammogram and further treatment. We analyzed the data using Starter version 18. We did both descriptive and inferential statistics. So the results and discussion. So this is the distribution of the patients that contributed to the study. Majority came from Kolebu Teaching Hospital, and CAT had the least number. So social demographic, majority of them were less than 40 old, and most of them had tertiary education. Most were also employed. The most common symptom, which was also seen in literature, was breast pain. That was the most common symptom, followed by breast mass, nipple discharge, axillary swelling, and skin changes. So based on our clinical examination, we found that the overall prevalence of abnormalities in breast was 12.9%. And the most abnormality detected by examination was breast mass, followed by nipple discharge, axillary lymph nodes, changes in skin, and nipple retraction, in that order. The majority of the lumps were found in the upper outer quadrant, and this was also in line with literature because most of the glands and ducts are found in that area of the breast. So it tends to be the most common part of breast abnormalities. Okay, so we did a bivariate analysis where we looked at the literature and took some factors that can influence the findings of breast abnormalities. So these are the prevalence that has been displayed. So you would see that we looked at the age group, the history, family history of breast cancer, history of breast cancer, and then exposure to radiation. These factors have been found to be associated with breast abnormalities. And we found out that the breast abnormalities was found more prevalent in those less than 40. Those with history of breast cancer had higher prevalence. Those with family history of breast cancer had higher prevalence. And those who had been exposed to radiation also had higher prevalence. So it was exactly as we expected. However, it wasn't statistically significant. The only significant one was the age group, that those younger than 40 years actually had a high prevalence. But this is bivariate analysis. We did a multivariate, which actually showed that it was not significant. Okay, so we also looked at lifestyle. So BMI, physical activity, alcohol intake, and smoking. All of them were significant by the bivariate analysis, except for smoking. However, there was an interesting finding, I don't know if most of us know, but actually being overweight and obese seemed to be protective against the breast abnormality findings. And when we looked at the literature, it's an interesting finding. So the benign breast masses, obesity and overweight is protective, again, especially in the young people, against benign breast masses. However, in older people, that's above 40 years, adiposity, that's having much weight, predisposes to cancer. So it's a very interesting thing that we found. Physical activity. Those who were not physically active had higher prevalence of breast abnormalities, and any amount of alcohol, it was a yes or no, was also associated with breast abnormality findings. And we also looked at hormone exposure. So menarche, age at menarche, parity, breastfeeding. And I mean, in this era, I mean, people are going child-free, but actually being parous was protective, and that was significant. The rest were not statistically significant. So this was the adjusted values. So we put all those that were significant together and we adjusted for it. At the end of the day, what we should take home is that BMI, alcohol, and physical activity after adjustment actually had an effect on breast cancer. Sorry, not breast cancer, but breast abnormalities. It was a general abnormality, not classified as cancer, but breast. Conclusion and recommendation is that breast screening by clinical breast examination as a breast screening tool in low resource settings is a good early detection tool, because we found 12.9% prevalence, which is actually which corresponds to what has been found elsewhere, and this supports using it as an early detection tool. And this actually points to further research. We should find out what adiposity has got to do with breast masses. So this should, I mean, influence further research. And policy, we realized that BMI, physical activity, and alcohol had a direct relation. So if we have some more policies on alcohol and we educate our patients about physical activities, that would be very helpful in breast health. Thank you very much. These are my references.
Thank you very much, Dr. Dufo. We're having some very interesting findings here. Okay, vis-a-vis lifestyle medicine. Okay, so we'll have a final presentation by the sponsor. That's EXFA. Is a rep here. If the representative. Okay, so. Right, let's welcome him.
Good afternoon, clinicians. So we are from EXFA Pharmaceuticals. My name is Kujo Osei-Wusu, and I'm with my colleague, Derek Adachi. So first and foremost, we'd like to thank the society for giving us the opportunity to present. And at EXFA for 40 years plus in Africa and 2 years in Ghana, we have been very much committed to providing highly efficacious and very affordable medications. So currently in Ghana, our portfolio comprises Antalgex T, which is our brand of paratramadol capsules, and then it gives an incidence of lower sedation, lower nausea and vomiting as compared to existing brands. We also have Exib, which is our scored Celecoxib 200 milligram. So it serves a dual. If your patient has or wants 200 milligram, they do get it. If there's the need for 100 milligram, you break it into two, and then they're able to get it. We are in the rainy season, so there will be instances of flu, fever, cough, etc. So we also have Febrilex Syrup Plus and then Febrilex Junior to cater for patients as such. We also have other ranges, but for the purpose of this presentation and time, we are going to focus on our latest addition to our portfolio, which is Trivalam H and then Gastricid. So when it comes to Gastricid, I'd like to present to you Amma, who is an example of everyday patient that you see in your clinic. So she comes to your clinic holding her chest, and her complaints are she has a burning sensation in the chest, irritation in the tummy. So when you look at the social history of Amma, she's a 32-year-old, a mother of one, and then her dietary conditions are not the best. She eats late, light, spicy food. If not because yesterday she didn't know the location of your party, she would have been there to join you. So Amma is suffering from differential diagnosis, what you call hyperacidity. So, of course, when the stomach has acid in it in the right place, there's no problem. But then the problem occurs when there's backflow into the esophagus, known as gastroesophageal acid. The prevalence of patients like Amma is more common than you can imagine. I dare say that each of us, if not all of us in this room, have had an experience of hyperacidity at one point in time. And as you can see from the statistics, 1 out of 3 patients in Nigeria, or out of 13 patients in Nigeria present with instances of hyperacidity. In urban areas in Ghana, 1 out of 4 patients. And most of the factors that contribute to that include H. pylori. Now you see that a staggering 88% of incidence of H. pylori. So 88% out of 100 population. In this room, you can do the math and know that lots of people may have H. pylori, which contributes to gastroesophageal reflux. So when it comes to a patient like Amma, of course, the first point of therapy will be to give antacids for symptomatic relief. Now, when it comes to antacids, most of what we have on the market have a short duration of therapy. That is how come the frequency of dosing, as I'm sure you are well aware, maybe 3 times a day, 4 times a day, and sometimes 6 times a day. That is because most of the antacids, magnesium hydroxide, calcium carbonate, are short-acting. So for a patient like Amma as well, you can see that it says in her presenting complaints that her symptoms worsens at night. So we do have antacids being given, but there's no coverage for the night time. So then the question is, how best can we offer proper acid control or coverage for a patient like Amma? So at XFAB, we brought a practical solution in what we call Gastricid. So Gastricid has your regular antacids, your calcium carbonate, and then your magnesium hydroxide. But then there's another element known as famotidine. So all these sum up to give you a triple therapy. Your antacids, calcium carbonate, magnesium hydroxide will give you fast onset of action, fast relief to neutralize the existing acid. But then it will not be sufficient for the nighttime. So then famotidine being available in as Gastricid will prevent extra secretion of acid that will cause extra irritation. So have it this way. Gastricid is available, fast onset of action with your 2 antacids, and prevents extra acid, which will cause problem, from being secreted with your famotidine. So the dosing is 1 chewable tablet twice a day for a maximum of 5 days. Very, very portable blister pack, 4 tabs in a blister pack, minty flavored. Can you imagine even the flavor of Gastricid has a use? Peppermint flavor. I'm sure most of you know that peppermint were used as sweets back in the day for after meals, just to help with acid control. So everything about Gastricid is to give superb acid control. So there are some studies just to show that the combination works better than the antacids alone and works better than famotidine alone. So you can see that within 5 to 15 minutes, Gastricid start working and then gives you relief maintained for more than 7 hours. And then we can see 70% extra efficacy as compared to antacids alone. So this one shows the nocturnal acid breakthrough that I was talking about. So your patients will be able to sleep properly without any problem of sleep disturbances. And then also this study highlights the fact that gastricid, yes, can be given to pregnant women as and when they are experiencing gastric esophageal reflux. So this is gastricid, and we can see Amma is very happy now after taking gastricid and swallowing some water. So please, there's gastricid available for everyone. We have a lot of samples to give. Visit our stand. If you want to take for your loved ones, we will give you. If we don't get for you, please write your name. We'll find you and come and give you some more. So I'll pass on the baton to my colleague to talk about Trivalam. Thank you very much. And Derek.
So thank you very much, Kojo. So from one success story to another. So I'm talking about management of hypertension patients in Trivalam H. But before I do so, I have a simple question to ask. So for our patients, we need to ask ourselves how many of them are on target for their blood pressures, and even for those who are not on target, how many of them are already on dual therapy and monotherapy. When you think about why many of our patients struggle to reach their blood pressure targets, what comes to mind? So that's the question I want to ask. So my name is Derek. Yes. So this brings us to what we call source-sensitive hypertension. So data points to something very, very important over here. So you realize that about 75% of Black individuals who have developed hypertension present with what we call source-sensitive hypertension. That is majority of the patients that come to our clinics. So this source-sensitive hypertension pattern is driven by a low renin phenotype in Blacks. So rather than the RAS system, the renin-angiotensin system being the force behind the blood pressure hypertension, it's rather driven by sodium retention. All right, so that is the primary force driving the hypertension in Black patients, and not necessarily the RAS system. So if volume overload is driving the pressure, does it make sense to only give therapies that block the RAS, and have what's of the volume components of these? So that's the biological foundation for most of the triple therapy combinations that we have. So you have something for the volume, which is going to be the diuretic hydrochlorothiazide in this scenario. Then you also have something for vascular resistance, where we usually use amlodipine. Then you need something for the neurohormonal activation, where we have valsartan, which is a RAS, works on the RAS. So as such, you are able to tackle the situation or the problem for the patient looking at all of these modalities. So Trivalam H, which is our product from XFAR, is built around these three distinct but very complementary mechanisms. Okay. So this combination is just rational pharmacologically, but it's exactly what most guidelines recommend for our patients. All right, so both the American Heart Association and the NICE guidelines for hypertension actually recommend that when it comes to uncontrolled hypertension on 2 agents, there's the need for a third agent, making it a triple therapy. So the question is not whether triple therapy is appropriate, all right? That has been answered by the guidelines which we adhere to. The question is rather, our patients who need it, are they actually getting it in a way that is very realistic? So this is where formulation matters, and this is where Trivalam H comes in, which is a titratable single tablet, which comes as a squad tablet, easy to break, and have a different strength for each the individual components. So I'd like to go over this study. So this is a clinical study published on hypertension. So in this study, it matters because they are comparing dual therapies and a placebo against a triple therapy. And as you have it, the mean systolic and diastolic blood pressures, you realize that the triple therapy has been able to have some drastic reductions in blood pressure as compared to the placebo and drug therapies. Then there's also another study, which is the Veronica study, just conducted in 2024 in Nigeria, but by one Dr. Oji. So if the general evidence from hypertension is not compelling enough, this study should be able to convince us why there's the need for triple therapy. So the Veronica study was conducted in Nigeria in Black African adults. It evaluated a low-dose triple therapy protocol against a standard care therapy. So at month 6, the mean home systolic blood pressure was an average of 31 millimeter mercury lower in the triple therapy group as compared to 26 millimeter mercury lower in the standard care protocol group, right? So evidence from this study shows that patients like ours, the ones we see every day, respond better to combination therapy than those than to the stepwise mono dual that we are usually used to. So Trivalam H comes in titratable tablets. It's amlodipine 10, 160, 12.5, amlodipine valsartan hydrochlorothiazide, and there are so many benefits of using Trivalam H. It allows for stepwise management for your patients, such that for a newly diagnosed hypertensive who already has a very, very high blood pressure, you are able to be a bit conservative and start with a half tablet a day, which is 580, 12.5. As such, a box of Trivalam H can last 2 months for such a patient at a very, very affordable price. So, and adherence for most of our patients, because this is a single tablet and they do not need to take multiple tablets, which is not going to help them in the long run. So if evidence says that triple therapy works and the guidelines support it, and the format we have Trivalam in makes it very manageable for the patients, what is preventing us or limiting us from initiating such a therapy for most of our patients? So that is the question I would like to leave us with. So to end our presentation, we would like to mention some of the institutions that we are present in with Trivalam and also some of our other products. So you have Kolebo Teaching Hospital, you have Confanoche, the Bank Hospital, UGMC 37, CCTH, just to mention but a few. Then also for pharmacies, you have all leading pharmacies nationwide, Top Up, Art Pharma, ECPL, Origin Chemist, yes. So beyond today's focus products, Trivalam and Gastricid, these are some of our other products, as Kojo rightly mentioned at the start of the presentation. Salgex, Exib, available in most of our institutions. Febrilex, a very, very unique formulation for managing flu. As we are getting ready to enter the rainy season, or already in the rainy season, I'm sure we'll need Febrilex around. Okay, so thank you so much for your attention. Thank you.
Thank you, Mr. Chairman.
So thank you very much, EXFA. Let's appreciate them. Okay, so can we have all the presenters come up the podium for our discussion session? So Dr. Francis Adai, Dr. Abrokwa, Dr. Obet Sapon, and then Abner Dufo. Please come up. Thank you. So we get one microphone going around. Okay, thank you. Thank you very much. I think we've had some very exciting research presentations, some of them quite interesting. So we'd like to, I'm opening the floor. First and foremost, congratulations Change to all of you. I don't know, but I'll ask you a question. All right. So, please, if you have a question, a comment, would like to see your hands up. Okay, I can see Dr. Igula Ogbe.
Thank you to everyone. Very interesting presentations. So Dr. Edufula, I want to find out about whether you'd want to follow up with the cases that you referred with abnormal breast lumps. Follow up. Would you want to follow up these clients with abnormal breast masses to determine what, the outcome of the referral was for those that probably were benign, those that were malignant? Is there a plan to do that? And I was curious to find out the number of those patients that smoked, because I saw 14% of, correct me if I'm wrong, but there was some association between those who smoked and those who had abnormal breast masses, unless I didn't see it right. Thank you very much.
Okay, so can we take some more questions or contributions if we have any? Okay, if not, we'll just ask it to answer. That question goes to Dr. Edufo, right? Okay. Are you okay?
Thank you very much.
That's right.
Yeah, thank you very much for your question. Yes, I think that follow-up is key in breast screening. So yes, we do have their numbers and we will follow them up to find out. And I think that if, depending on what we find, we might also add to what we have. Yes, the smoking, I don't have it off the top of my head, but I think the prevalence of breast abnormalities in those not smoking was higher than those smoking. And it was not, the difference in the prevalence was not statistically significant. So we can't say if it had an effect. Thank you.
Okay, thank you very much. Yes, please. Where's the microphone? Yes, please. Okay. Introduce yourself and ask your question or give your comment.
Okay, so I think my question is about the on the antibiotic resistance.
Will you kindly introduce yourself?
Oh, okay, sorry. So my name is Dr. Jean-Benedict Rubaiza. So family physician. I'm in private practice, Mother of God Hospital. So I think my question is on the antibiotic resistance. So I really love the idea of the determining an antibiogram, what the resistance patterns are, and then being able to act on them. But I was concerned about the fact that we have guidelines for, I'm talking about claims reimbursement in this instance. So for example, NHIS relying on information which is probably outdated, but that is what is spelled out in the standard treatment guidelines. So should we, if as a facility, we should determine what the patterns are and then make changes to what we do. I was wondering if maybe what your work can be used to maybe bring a little freedom in first-line therapy for empiric management of common conditions based on these findings. Thank you.
Yeah, would you want to? Okay, there's a hand here, Dr. Aye.
Thank you, Dr. Niaye, Port Medical Center. Yes, to the issues about the use of antibiotics. Now, for our generation, the aminoglycosides were no go until sensitivity tests have been done. Now, can you make me comfortable? Because if I heard you right, you said you are using them as, first line and precisely as a preventive first line. Thank you.
Okay, so I think just that you can take the
All right,
questions.
Prof. Thank you for the opportunity. So I'll start off with Dr. Aye's concern. So we only use amikacin specifically for our empiric treatment. So let's say we have a surgical site infection. We've taken samples. We are waiting cultures. Amikacin is one of our pillars. And the reason is that of all the antibiogram we have, beyond the carbapenems, the next available to us is amikacin. So whatever combination we are choosing, amikacin is one of it. We don't use it prophylactically. So as an institution, we have something we call care bundles. So the care bundles are the common infections we see within the hospital. One of them, the commonest from my presentation, if you realize, was CAUTI, which is catheter-associated urinary tract infection. Because we do extensive spine surgeries, which some can last as high as 8 hours, our risks of these infections are high. So once we have any of those care bundles as an infection, one of our pillars definitely will be amikacin, because we have the CAUTI, we have the CLABSI, which is our central line, bloodstream infections. We have our hospital-acquired pneumonias. We have urosepsis. So we have 5 top. And anytime we have to choose empirically, we make sure that amikacin, of course, we do due diligence and make sure renal function and everything is fine. So we do our baselines and we make sure that the patients are well hydrated. So this is an institutional thing. And if you look at my conclusion, it's one of the recommendations we made. And I'll tie my last point, Doug, with your submission. One of the recommendations we made was local surveillance. We need a lot of data. In fact, work done by Dr. Samoa and MDS Lancet looking at urinary isolates that was published about 3 years ago, over 20,000 isolates. In fact, they made a strong statement that our standard treatment guidelines when it comes to treating uncomplicated urinary tract infection has to change. Because in that paper, they realized that resistance to quinolones and second-generation cephalosporins, cefuroxime and Cipro, which we're using for our uncomplicated UTIs, were not working. And that has influenced policy. The current guideline is not out yet, but at some levels, I know, and in our practice, I don't know how many of us still prescribe cefuroxime for uncomplicated UTI because it will not work. Cipro will not work, and the evidence is there. And in fact, our findings at Focus also supports to a large extent. So I believe as we all do some work and put it together, we'll be able to influence what happens at the national level. Yeah, so that will be my...
Hello. No, I think sometimes the mic. Hello.
Yes. So I don't know if my submission answers your question. Yes. So what we are recommending is there should be more work in the area of research within your institutions. It can be multi-centered, but if you are able to, we have done a 5-year prospective study. And it's under review for publication. But until it is published, as an institution, we definitely have to change our antibiogram to suit our findings. You get it?
Yeah. Hello. Okay. I think I'm on. Okay. Thank you very much. So, can we take maybe last 2 submissions? Okay. Yes. Let's hear you. If the microphone is working, I think it's, yeah. Please introduce yourself and then.
Thank you. My name is Dr. Giwa Adenike from Kumasi.
I wanted to find out concerning the clinical breast examination and the obesity you were talking about. Could it, we know the CBEs will definitely pick about 44 to 60% of breast masses. But when they are obese, we know it's difficult to pick, especially small lumps or masses. Could it be that that was why I don't know, it's a question, you weren't really picking masses in the obese clients and feeling maybe that could be protective, or you didn't get? Okay, I was saying.
I believe she cannot hear you well, so
Oh,
just
okay.
speak.
Concerning the clients that were obese and then their clinical breast findings, I was saying I know clinical breast examinations might not pick very small masses, and if they are obese and they have big breasts, it could also further be difficult to pick those masses. Could that be, do you think that could be one of the reasons why you are not picking masses in the patients that are obese? And would you rather follow them up with maybe a clinical a scan in the future to see if it's so? Thank you.
Thank you very much. I think that's a very excellent observation. That could be, I mean, aside those that presented with symptoms of a mass, they were sent for screening, but once they didn't have symptoms of a mass, and we also didn't pick up any, those were not necessarily, I mean, referred for screening. But I think we should look in it and see if, I mean, they being obese might lead to less detection of that. So maybe we should carry out a research and then actually screen with mammogram and ultrasound all those that are overweight and obese and see those that we missed. And I think that would be a very good research. So thank you very much.
Thank you. Any other person? Okay.
All right. So, so this is Dr. Jean Benoit again. So, my question is for Dr. Obed. I wanted to find out on the PDQR9, whether the administration was primarily on paper or there were online forms as well. And I don't know whether that made any difference. I'm talking about in terms of access, I mean, accessibility for the patients. And then for Dr. Nanekia, on the online health system, sorry, the online, what do you call it, appointment system for the University Health Services. What has been the experience so far? If it has been applied, and whether the access is mainly through an app, like a standalone app, or if it's available online, like freely. Thank you.
Okay.
Okay, yeah.
Thank you very much for the question. So the tool is paper-based, but it can be converted into electronic. And we are not doing electronic now because the system, the electronic health record that we are using now, we don't have the patient interface. It's supposed to have two interfaces. We have the hospital side and the patient side. So this tool is a patient-reported experience measure, which means that it is the patient who is giving their assessment or perception about the care. And it should be devoid of any clinical person interpretation or family member interpretation. So it is the patient and patient alone. So when we get to that system, then we can incorporate those tools into our electronic health record, and then patient can actually answer that even before they come to the clinic. The same will apply to other tools that we have been using, which most of them have not been validated in Ghana. So contextually, we may be using it. We are getting ideas or results, and we are using it for management, but we have to check the differences. Thank you.
Thank you, Dr. Obed. When were the patients interviewed? I mean, how soon on exit from the consulting room, or was it sometime later on?
So this will exit patient immediately after the consultation. So we did that because we didn't want a limitation where there will be recall bias. We wanted to minimize that. So immediately after the consultation, the patient is seen, and then we discuss with the patient. If the patient consents to be part of the study, the patient is sent to a different room where there is no staff or anybody to cause inconvenience to the patients. And the patient answers the questions according to his or her own will. And there was no injunction to objection.
Thank you.
Thank you. Thank you very much. So the app is it's a web-based app. It's currently active, and it's one of the piloting apps that we've been using for the hospital. So we had the family practice module initially. Now we have the student online health appointment system. And we are hoping to also operationalize the TechMed app, where you'll be able to go online, and that will also streamline a lot of wider-based interventions for the university hospital as well as a whole. So yes, it is active. Thank you.
Thank you very much. Ladies and gentlemen, I think there's a very good point to bring this session to an end. Very grateful to our presenters. They've really, made some very good presentations, very sound and scientific processes, and I think this is very encouraging. My question to all the presenters, maybe except probably just one person, is that all these presentations you've made could qualify for your fellowship. Yes, so you are doing the research. So let's see some more applications next time around for the fellowship, and that so that you really come out and also augment the faculty. So you've done very, very well and excellent presentations. And shall we all give them a round of applause? So, welcome. So next AGSM, I expect that we'll have more presentations. It would have been good to maybe have a book of abstracts so we could preview them before coming. And I also want to suggest to the executives that as part of boosting up our research, it should be everybody's interest. So every training center, they should be able to make a presentation. It could just be a poster. So we could have just had posters all around the place with every training center making a presentation. It could be a case series, case presentation. It could be an innovation in medical education. It could be a quality improvement project, etc. So training center by training center, you all bunch up together and make a presentation, and that is going to further enrich our scientific section. Thank you very much for being a very good audience. I want to hand over to the President. Yes, thank you.
Thank you very much. And lunch is served. I'm so sorry for the delay, but this has taught us that Suffolk is growing. There are so many things we are doing. In future, we may think about doing different sessions for different scientific presentations so that we can keep to time. So apologies. Please kindly move to the restaurant. You'll be given a coupon. Make sure you get one, and then indulge yourself with a different variety of food that is served. Our AGM, which is the highest decision-making body, is supposed to start at 4 p.m. So kindly grab, it's almost 3. So apologies. I'll apologize till tomorrow. So kindly grab something to eat, stretch up a bit, and come. There are so many things to discuss. As you see, Suffolk is going. So don't stay in your rooms, and let's start the meeting on time so that we can have our evening dinner session. the lunch is where we had a seat PD yesterday. So kindly move there. Thank you so much.
Warm greetings from the Society of Laboratory Physicians, Ghana. On the occasion of the 12th Annual General and Scientific Meeting of the Society of Family Physicians, Ghana, we congratulate you and we solidarize with your distinguished society. Your theme for this year, strengthening primary healthcare through compassion and digital innovation, is timely and is forward-looking. As partners in healthcare, we look forward to collaborating with you and to advancing health delivery in Ghana. Thank you.
I bring you greetings from the West African College of Physicians, the Ghana chapter, and the Ghanaian Society of Cardiology. I am Dr. Collins Kukru, the president of the Ghanaian Society of Cardiology and also the national secretary of the West African College of Physicians, Ghana chapter. This fraternal greetings is to the Society of Family Physicians of Ghana on the occasion of your 12th Annual General and Scientific Meeting, which is taking place in the beautiful city of Takoradi in Ghana. It is both fitting and forward-looking that this year's theme that you have chosen, Strengthening Primary Healthcare Through Compassion and Digital Innovation, highlights two indispensable pillars of modern healthcare delivery. Compassion remains the enduring foundation of family medicine, anchoring trust, dignity, and patient-centered care, while digital innovation presents unprecedented opportunities to expand access, enhance efficiency, and improve quality outcomes across healthcare systems. The mission of the Ghanaian Society of Cardiology is to advance cardiovascular knowledge and practice while promoting prevention and effective management of heart disease and non-communicable diseases. And at the West African College of Physicians, our vision is to promote excellence in postgraduate medical education, foster high standards of clinical practice, and advance research for improved healthcare outcomes across the sub-region. Your chosen theme for this year's AGSM strongly resonates with this mission and vision of the two associations. Strengthening primary healthcare systems through empathic, patient-focused approach and augmented by appropriate digital technologies directly aligns with our commitment to building resilient, equitable, and sustainable systems in West Africa. Family physicians remain the cornerstone of primary health care and serve as essential drivers in achieving universal health coverage. The integration of digital tools into clinical practice, ranging from telemedicine to health information systems, offers informative potential, especially in underserved communities. However, it is the compassionate deployment of these innovations that ensures they truly serve the needs of our people and uphold the core values of medical practice. We commend the Society of Family Physicians of Ghana for your sustained leadership, dedication to capacity building, and advocacy for excellence in family medicine in Ghana. Your efforts continue to inspire collaboration across special. Hello, good morning. I bring you greetings from the West African College of Physicians, the Ghana chapter, and the Ghanaian Society of Cardiology. I am Dr. Collins Kukru, the president of the Ghanaian Society of Cardiology.
Warm greetings from the Society of Laboratory Physicians, Ghana. On the occasion of the 12th Annual General and Scientific Meeting of the Society of Family Physicians, Ghana, we congratulate and we solidarize with your distinguished society. Your theme for this year, strengthening primary healthcare through compassion and digital innovation, is timely and is forward-looking. As partners in healthcare, we look forward to collaborating with you and to advancing health delivery in Ghana. Thank you. Warm greetings from the Society of Laboratory Physicians, Ghana. On the occasion of the 12th Annual General and Scientific Meeting of the Society of Family Physicians, Ghana, we congratulate and we solidarize with your distinguished society. Your theme for this year, strengthening primary healthcare through compassion and digital innovation, is timely and is forward-looking. As partners in healthcare, we look forward to collaborating with you and to advancing health delivery in Ghana. Thank you.
Also, the National Secretary of the West African College of Physicians, Ghana chapter. This fraternal greetings is to the Society of Family Physicians of Ghana on the occasion of your 12th Annual General and Scientific Meeting, which is taking place in the beautiful city of Takoradi in Ghana. It is both fitting and forward-looking that this year's theme that you have chosen, strengthening primary health care through compassion and digital innovation, highlights two indispensable pillars of modern healthcare delivery. Compassion remains the enduring foundation of family medicine, anchoring trust, dignity, and patient-centered care, while digital innovation presents unprecedented opportunities to expand access, enhance efficiency, and improve quality outcomes across healthcare systems. The mission of the Ghanaian Society of Cardiology is to advance cardiovascular knowledge and practice while promoting prevention and effective management of heart disease and non-communicable diseases. And at the West African College of Physicians, our vision is to promote excellence in postgraduate medical education, foster high standards of clinical practice, and advance research for improved healthcare outcomes across the sub-region. Your chosen theme for this year's AGSM strongly resonates with this mission and vision of the two associations. Strengthening primary healthcare systems through empathic, patient-focused approach and augmented by appropriate digital technologies directly aligns with our commitment to building resilient, equitable, and sustainable health systems in West Africa. Family physicians remain the cornerstone of primary health care and serve as essential drivers in achieving universal health coverage. The integration of digital tools into clinical practice, ranging from telemedicine to health information systems, offers informative potential, especially in underserved communities. However, it is the compassionate deployment of these innovations that ensures they truly serve the needs of our people and uphold the core values of medical practice. We commend the Society of Family Physicians of Ghana for your sustained leadership, dedication to capacity building, and advocacy for excellence in family medicine in Ghana. Your efforts continue to inspire collaboration across special. Hello, good morning. I bring you greetings from the West African College of Physicians, the Ghana chapter, and the Ghanaian Society of Cardiology. I am Dr. Collins Kukru, the president of the Ghanaian Society of Cardiology, and also the National Secretary of the West African College of Physicians Ghana chapter. This fraternal greetings is to the Society of Family Physicians of Ghana on the occasion of your 12th annual general and scientific meeting, which is taking place in the beautiful city of Takoradi in Ghana. It is both fitting and forward-looking that this year's theme that you have chosen, strengthening primary health care through compassion and digital innovation, highlights two indispensable pillars of modern healthcare delivery. Compassion remains the enduring foundation of family medicine, anchoring trust, dignity, and patient-centered care, while digital innovation presents unprecedented opportunities to expand access, enhance efficiency, and improve quality outcomes across healthcare systems. The mission of the Ghanaian Society of Cardiology is to advance cardiovascular knowledge and practice while promoting prevention and effective management of heart disease and non-communicable diseases. And at the West African College of Physicians, our vision is to promote excellence in postgraduate medical education, foster high standards of clinical practice, and advance research for improved healthcare outcomes across the sub-region. Your chosen team for this year's AGSM strongly resonates with this mission and vision of the two associations. Strengthen primary healthcare systems through empathic, patient-focused approach and augmented by appropriate digital technologies directly aligns with our commitment to building resilient, equitable, and sustainable health systems in West Africa. Family physicians remain the cornerstone of primary health care and serve as essential drivers in achieving universal health coverage. The integration of digital tools into clinical practice, ranging from telemedicine to health information systems, offers informative potential, especially in underserved communities. However, it is the compassionate deployment of these innovations that ensures they truly serve the needs of our people and uphold the core values of medical practice. We commend the Society of Family Physicians of Ghana for your sustained leadership, dedication to capacity building, and advocacy for excellence in family medicine in Ghana. Your efforts continue to inspire collaboration across special. Hello, good morning. I bring you greetings from the West African College of Physicians, the Ghana chapter, and the Ghanaian Society of Cardiology. I am Dr. Collins Kukru, the president of the Ghanaian Society of Cardiology and also the national secretary of the West African College of Physicians, Ghana chapter. This fraternal greetings is to the Society of Family Physicians of Ghana on the occasion of your 12th annual general and scientific meeting, which is taking place in the beautiful city of Takoradi in Ghana. It is both fitting and forward-looking that this year's theme that you have chosen, strengthening primary health care through compassion and digital innovation, highlights two indispensable pillars of modern healthcare delivery. Compassion remains the enduring foundation of family medicine, anchoring trust, dignity, and patient-centered care, while digital innovation presents unprecedented opportunities to expand access, enhance efficiency, and improve quality outcomes across healthcare systems. The mission of the Ghanaian Society of Cardiology is to advance cardiovascular knowledge and practice while promoting prevention and effective management of heart disease and non-communicable diseases. And at the West African College of Physicians, our vision is to promote excellence in postgraduate medical education, foster high standards of clinical practice, and advance research for improved healthcare outcomes across the sub-region. Your chosen team for this year's AGSM strongly resonates with this mission and vision of the two associations. Strengthening primary health care systems through empathic, patient-focused approach and augmented by appropriate digital technologies directly aligns with our commitment to building resilient, equitable, and sustainable health systems in West Africa. Family physicians remain the cornerstone of primary health care and serve as essential drivers in achieving universal health coverage. The integration of digital tools into clinical practice, ranging from telemedicine to health information systems, offers informative potential, especially in underserved communities. However, it is the compassionate deployment of these innovations that ensures they truly serve the needs of our people and uphold the core values of medical practice. We commend the Society of Family Physicians of Ghana for your sustained leadership, dedication to capacity building, and advocacy for excellence in family medicine in Ghana. Your efforts continue to inspire collaboration across special. Hello, good morning. I bring you greetings from the West African College of Physicians, the Ghana chapter, and the Ghanaian Society of Cardiology. I am Dr. Collins Kukru, the president of the Ghanaian Society of Cardiology and also the national secretary of the West African College of Physicians, Ghana chapter. This fraternal greetings is to the Society of Family Physicians of Ghana on the occasion of your 12th annual general and scientific meeting, which is taking place in the beautiful city of Takoradi in Ghana. It is both fitting and forward-looking that this year's theme that you have chosen, Strengthening Primary Health Care Through Compassion and Digital Innovation, highlights two indispensable pillars of modern healthcare delivery. Compassion remains the enduring foundation of family medicine, anchoring trust, dignity, and patient-centered care, while digital innovation presents unprecedented opportunities to expand access, enhance efficiency, and improve quality outcomes across healthcare systems. The mission of the Ghanaian Society of Cardiology is to advance cardiovascular knowledge and practice while promoting prevention and effective management of heart disease and non-communicable diseases. And at the West African College of Physicians, our vision is to promote excellence in postgraduate medical education, foster high standards of clinical practice, and advance research for improved healthcare outcomes across the sub-region. Your chosen team for this year's AGSM strongly resonates with this mission and vision of the two associations. Strengthening primary healthcare systems through empathic, patient-focused approach and augmented by appropriate digital technologies directly aligns with our commitment to building resilient, equitable, and sustainable health systems in West Africa. Family physicians remain the cornerstone of primary health care and serve as essential drivers in achieving universal health coverage. The integration of digital tools into clinical practice, ranging from telemedicine to health information systems, offers informative potential, especially in underserved communities. However, it is the compassionate deployment of these innovations that ensures they truly serve the needs of our people and uphold the core values of medical practice. We commend the Society of Family Physicians of Ghana for your sustained leadership, dedication to capacity building, and advocacy for excellence in family medicine in Ghana. Your efforts continue to inspire collaboration across special. Hello, good morning. I bring you greetings from the West African College of Physicians, the Ghana chapter, and the Ghanaian Society of Cardiology. I am Dr. Collins Kukru, the president of the Ghanaian Society of Cardiology and also the national secretary of the West African College of Physicians, Ghana chapter. This fraternal greetings is to the Society of Family Physicians of Ghana on the occasion of your 12th annual general and scientific meeting, which is taking place in the beautiful city of Takoradi in Ghana. It is both fitting and forward-looking that this year's theme that you have chosen, Strengthening Primary Healthcare Through Compassion and Digital Innovation, highlights two indispensable pillars of modern healthcare delivery. Compassion remains the enduring foundation of family medicine, anchoring trust, dignity, and patient-centered care, while digital innovation presents unprecedented opportunities to expand access, enhance efficiency, and improve quality outcomes across healthcare systems. The mission of the Ghanaian Society of Cardiology is to advance cardiovascular knowledge and practice while promoting prevention and effective management of heart disease. For its unwavering commitment to advancing family medicine and strengthening healthcare delivery in Ghana through continuous professional development, advocacy, research, and patient-centered care. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is both timely and visionary. As healthcare systems across the world evolve, the integration of compassion with technological advancement remains essential while ensuring equitable, accessible, and quality healthcare for all. At MSOC, we recognize the indispensable role family physicians play as the foundation of primary healthcare and as critical partners in the continuum of emergency and acute care services in the country. Your dedication to holistic care, preventive medicine, and community health continues to positively impact countless lives across the nation. We are particularly encouraged by the focus on digital innovation, which offers tremendous opportunities to improve healthcare access, enhance communication, optimize patient outcomes, and strengthen collaboration among healthcare professionals. As colleagues united by a common goal of improving healthcare delivery in Ghana, MSOC reaffirms its support for stronger interdisciplinary collaboration between emergency medicine and family medicine in building resilient and responsive health systems. We want to wish SOFPOC a successful and impactful 12th AGSL filled with fruitful deliberations, knowledge sharing, and renewed commitment to excellence in healthcare. Long live SOFPOC, long live MSOC, and long live Ghana's healthcare community. Thank you. Greetings from the Emergency Medicine Society of Ghana, MSOC. MSOC extends its warm congratulations and fraternal solidarity to the Society of Family Physicians of Ghana, SOFPOC, on the occasion of your 12th annual general and scientific meeting. We commend SOFPOC for its unwavering commitment to advancing family medicine and strengthening healthcare delivery in Ghana through continuous professional development, advocacy, research, and patient-centered care. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is both timely and visionary. As healthcare systems across the world evolve, the integration of compassion with technological advancement remains essential while ensuring equitable, accessible, and quality healthcare for all. At MSOC, we recognize the indispensable role family physicians play as the foundation of primary healthcare and as critical partners in the continuum of emergency and acute care services in the country. Your dedication to holistic care, preventive medicine, and community health continues to positively impact countless lives across the nation. We are particularly encouraged by the focus on digital innovation, which offers tremendous opportunities to improve healthcare access, enhance communication, optimize patient outcomes, and strengthen collaboration among healthcare professionals.
As colleagues united by a common goal of improving healthcare delivery in Ghana, MSOG reaffirms its support for stronger interdisciplinary collaboration between emergency medicine and family medicine in building resilient and responsive health systems. We want to wish SOFPOC a successful and impactful 12 AGSL filled with fruitful deliberations, knowledge sharing, and renewed commitment to excellence in healthcare. Long live SOFPOC, long live MSOG, and long live Ghana's healthcare community. Thank you. Greetings from the Emergency Medicine Society of Ghana, MSOG. MSOG extends its warm congratulations and fraternal solidarity to the Society of Family Physicians of Ghana, SOFPOC, on the occasion of your 12th Annual General and Scientific Meeting. We commend SOFPOC for its unwavering commitment to advancing family medicine and strengthening healthcare delivery in Ghana through continuous professional development, advocacy, research, and patient-centered care. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is both timely and visionary. As healthcare systems across the world evolve, the integration of compassion with technological advancement remains essential in ensuring equitable, accessible, and quality healthcare for all. At MSOG, we recognize the indispensable role family physicians play as the foundation of primary healthcare and as critical partners in the continuum of emergency and acute care services in the country. Your dedication to holistic care, preventive medicine, and community health continues to positively impact countless lives across the nation. We are particularly encouraged by the focus on digital innovation, which offers tremendous opportunities to improve healthcare access, enhance communication, optimize patient outcomes, and strengthen collaboration among healthcare professionals. As colleagues united by a common goal of improving healthcare delivery in Ghana, MSOG reaffirms its support for stronger interdisciplinary collaboration between emergency medicine and family medicine in building resilient and responsive health systems. We want to wish SOFPOC a successful and impactful 12 AGSL filled with fruitful deliberations, knowledge sharing, and renewed commitment to excellence in healthcare. Long live SOFPOC, long live MSOG, and long live Ghana's healthcare community. Thank you. Greetings from the Emergency Medicine Society of Ghana, MSOG.
Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takoradi. Congratulations. Your theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the communities and on the front lines. I'm also excited that your theme is looking at compassion and digital innovation. These are going to be critical and will help to bridge the gap and help to improve access to children across the various communities, especially within the underserved areas. Now, on a lighter note, I know many of you family physicians are actually pediatricians at heart, and so we are happy to join you today as you deliberate on these very important issues. Thank you for the invitation, and we wish you the very best in this conference. We look forward to continuing to work with you and to partner on improving access to children across the country. Thank you. Bye-bye. Hello, everyone. I bring you warm greetings from the Pediatric Society of Ghana. On behalf of the society, I'd like to congratulate you on the successful organization of your 12th AGSM in Takoradi. Congratulations. Your theme, strengthening primary health care through compassion and digital innovation, is apt. The World Health Organization notes that primary health care can address over 80% of a person's essential health needs throughout their lifetime. From the pediatric perspective, strong primary health care is critical to reducing preventable childhood illnesses and deaths through immunization, early diagnosis, nutrition support, health education, and timely referrals. With nearly 5 million children under 5 years still dying from preventable causes annually, your role as family physicians remains indispensable, especially within the communities and on the front lines. I'm also excited that your theme is looking at compassion and digital innovation. These are going to be critical and will help to bridge the gap and help to improve access to children across the various communities, especially within the underserved areas. Now, on a lighter note, I know many of you family physicians are actually pediatricians at heart, and so we are happy to join you today as you deliberate on these very important issues. Thank you for the invitation, and we wish you the very best in this conference. We look forward to continuing to work with you and to partner on improving access to children across the country. Thank you. Bye-bye. Hello, everyone.
Hi, my name is Vincent Bizonachina, and I welcome all family physicians to the Western Division on behalf of myself and the executives of GMA Western Division. I am happy that you guys chose to have your 12th AGM in our division under the title Strengthening Primary Healthcare Through Compassion and Digital Innovation. Sekedi Takoradi, as you all know, is the Twin City. It is also the Oil City, and so there's a lot to see and a lot to enjoy in the division, even as you need to discuss how to better the practice of family medicine in the country and how to even push primary health care, and then even the agenda of Ghana Medical Association as a whole. I pray that you also make some time to enjoy the sights and sounds of Sekedi Takoradi. You have my full support, and we the executives are ready to help you in any way, shape or form that will make your stay in Takoradi a success. Enjoy your AGM. Even though I'm not there physically with you, I send you my love, my blessings, and my other executives are there should you need them. They are ever ready to help you. Enjoy your stay, and we await the communique that to come out of this AGM, and we are sure that it is going to help strengthen our practice of medicine in Ghana. Enjoy your stay, and welcome to the Western Division. Hi.
Dear esteemed members of the Society of Family Physicians of Ghana, SOFCOG, it is with immense pride and solidarity that I extend my warmest greetings to you all during your 12th annual General and Scientific meeting in the beautiful city of Takoradi. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is not just timely but critical in our ongoing mission to enhance healthcare outcomes for all Ghanaians. As we gather to share knowledge and insights, let us reflect on the vital role of primary healthcare in our healthcare delivery system. It is a cornerstone of our nation's health services, and the dedication of family physicians is indispensable. Your commitment to compassionate care and the integration of digital innovation embodies the future of healthcare delivery, ensuring that our communities not only receive quality care, but also access it efficiently. In the face of the evolving challenges, the importance of collaboration among health professionals cannot be overstated. The Ghana Medical Association stands firmly with you in your endeavors to promote evidence-based practices and utilize technology to bridge healthcare gaps. Together, we can empower a healthcare workforce and uplift the lives of countless individuals. Let us harness the spirit of togetherness as we work towards a healthier Ghana, where every citizen can thrive in an environment of compassion and accessibility. I encourage all members to engage actively in the discussions and workshops over the coming days, as your contributions are pivotal in shaping the future of family medicine in this country. In solidarity and shared purpose, I say Ayipo, long live GMA, long live Ghana. Thank you. Good day, colleagues. Dear esteemed members of the Society of Family Physicians of Ghana, SOFCOG, it is with immense pride and solidarity that I extend my warmest greetings to you all during your 12th annual General and Scientific meeting in the beautiful city of Takoradi. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is not just timely but critical in our ongoing mission to enhance healthcare outcomes for all Ghanaians. As we gather to share knowledge and insights, let us reflect on the vital role of primary healthcare in our healthcare delivery system. It is a cornerstone of our nation's health services, and the dedication of family physicians is indispensable. Your commitment to compassionate care and the integration of digital innovation embodies the future of healthcare delivery, ensuring that our communities not only receive quality care, but also access it efficiently. In the face of the evolving challenges, the importance of collaboration among health professionals cannot be overstated. The Ghana Medical Association stands firmly with you in your endeavors to promote evidence-based practices and utilize technology to bridge healthcare gaps. Together, we can empower a healthcare workforce and uplift the lives of countless individuals. Let us harness the spirit of togetherness as we work towards a healthier Ghana, where every citizen can thrive in an environment of compassion and accessibility. I encourage all members to engage actively in the discussions and workshops over the coming days, as your contributions are pivotal in shaping the future of family medicine in this country. In solidarity and shared purpose, I say Ayipo, long live GMA, long live Ghana. Thank you. Good day, colleagues. Dear esteemed members of the Society of Family Physicians of Ghana, SOFCOG, it is with immense pride and solidarity that I extend my warmest greetings to you all during your 12th annual General and Scientific meeting in the beautiful city of Takoradi. This year's theme, Strengthening Primary Healthcare Through Compassion and Digital Innovation, is not just timely but critical in our ongoing mission to enhance healthcare outcomes for all Ghanaians. As we gather to share knowledge and insights, let us reflect on the vital role of primary healthcare in our healthcare delivery system. It is a cornerstone of our nation's health services, and the dedication of family physicians is indispensable. Your commitment to compassionate care and the integration of digital innovation embodies the future of healthcare delivery, ensuring that our communities not only receive quality care, but also access it efficiently. In the face of the evolving challenges, the importance of collaboration among health professionals cannot be overstated. The Ghana Medical Association stands firmly with you in your endeavors to promote evidence-based practices and utilize technology to bridge healthcare gaps. Together, we can empower a healthcare workforce and uplift the lives of countless individuals. Let us harness the spirit of togetherness as we work towards a healthier Ghana, where every citizen can thrive in an environment of compassion and accessibility. I encourage all members to engage actively in the discussions and workshops over the coming days, as your contributions are pivotal in shaping the future of family medicine in this country. In solidarity and shared purpose, I say Ayiko, long live GMA, long live Ghana. Thank you. Good day, colleagues. Dear esteemed members of the Society of Family Physicians of Ghana, SOFCOG,